So what you're looking at right now here is that you're looking at the transverse section of a spinal cord. Obviously, there's a dorsal and the ventral can be seen on this side. That's a dorsal here. This is the ventral. So you can appreciate this dorsal horn of the spinal cord. This here is the ventral horn. And here we have the lateral horn. As we know that lateral horn of spinal cord is not present everywhere. Lateral horn can be seen only in the region where the spinal cord need to give the preganglionic sympathetic or parasympathetic neuron. So it's either in the thoracolumbar region or in the sacral region where you find these lateral horns. Otherwise, spinal cord is just having the dorsal and the ventral horn. In this lateral horn, we have a set of nuclei present here. We simply call it the lateral horn nuclei, although we have two parts of lateral horn nuclei called as a intermediolateral, intermediomedial, but we don't have to go into that detail. This nuclei here is the lateral horn nuclei. This is a lateral horn nuclei, and needless to say, this lateral horn nuclei is autonomic. So it will give rise to the sympathetic as well as the parasympathetic neurons. The preganglionic sympathetic or parasympathetic neuron depends upon where we are looking at it. Well, today we are discussing about the sympathetic chain, so we are just focusing on the lateral horn nuclei, which are in the sympathetic region. And what is the sympathetic region? When we say sympathetic outflow, I'm sure you all heard of the term sympathetic outflow. Guys, sympathetic outflow, it refers to the thoracolumbar outflow. Sympathetic outflow is a thoracolumbar outflow. We know that craniosacral outflow is a parasympathetic nervous system. That's a parasympathetic nerves coming out from the cranium and the sacral region. And sympathetic nerves, they come out from the thoracolumbar region, the thoracolumbar outflow. And this thoracolumbar outflow, it extends from T1 to L2. It can be L3 also, but usually it's still L2. So from first thoracic nerve to the second lumbar nerve, the nerves which are coming out from this region are the ones which are forming preganglionic sympathetic neurons. They are the ones which will form preganglionic sympathetic neurons. So that's one thing, that whatever we discussed today, the preganglionic nerve will be coming out only from this T1 to L2 region. Although these preganglionic nerve and the postganglionic nerve coming out of this sympathetic chain will be having the different destinations. Okay. So before we go to this about this sympathetic outflow, now as you can see, this here obviously is the dorsal root of the spinal nerve, and this one here is the ventral root. And as you can see, the dorsal and ventral root they fuse and they form a spinal nerve over there. And along with the dorsal root, you can also appreciate this dorsal root ganglia. That's a dorsal root ganglia. You know, dorsal root ganglia is holding those pseudo-unipolar neurons for the nerves which are carrying the sensation toward the spinal cord. So they make their pseudo-unipolar neuron here in the dorsal root ganglia, and then they finally go into the dorsal horn. Like pseudo-unipolar neuron in central nervous system were present only in mesencephalic nucleus. But pseudo-unipolar neurons, they are present at various locations when we talk about peripheral nervous system. In peripheral nervous system, like even trigeminal ganglion, geniculate ganglion, dorsal root ganglia, they all have pseudo-unipolar neurons. This is one of the site of pseudo-unipolar neuron, that is dorsal root ganglia. Then what you see, this dorsal root and the ventral root, when they fuse with each other, they form this spinal nerve, and this spinal nerve is seen connected to this sympathetic ganglion. It's connected to the sympathetic ganglion, and it is connected to sympathetic ganglion by these two roots, one, this one and this one. The one which is proximal, the one which is closer to the spinal cord, is called as the gray ramus communicans. This is the one which is called as the gray ramus communicans. Let's call it GRC from now, gray ramus communicans. And the one which is more distally placed is called as the white ramus communicans. Let's call it WRC. Gray ramus communicans and white ramus communicans. Now the thing is, the white ramus communicans and gray ramus communicans, the name is given based on the myelination and non-myelination. When you say white ramus communicans, then this is the root which is having mainly the myelinated neurons. Myelinated axons are present there. And the gray ramus communicans is the one which is having the non-myelinated axons. It's having the non-myelinated axons. But it's not that simple, guys. Myelinated axon doesn't mean that the white ramus communicans is only having this myelinated axon. We call it white ramus communicans because of the myelin sheath, giving it more of a whitish appearance. But this myelinated axons are way more than non-myelinated here. That means in the white ramus communicans, that's an important thing, that in white ramus communicans, we not only have the myelinated axons, we do have some non-myelinated axons as well. And where they're coming from, we will discuss that in a while. So first we need to look at the anatomical location of the ganglion, then how it is connected to spinal nerve, and then we can talk about that, what nerve fibers are running into it. So this is what, that we have a spinal nerve which is connected to the sympathetic chain, the ganglion of the sympathetic chain, by the two roots. The proximal one is the gray ramus, and the one which is distal is called the white ramus communicans. And just for the memory's sake, if I ask you this, remember this G and W. Well, G gray ramus communicans, W is white ramus communicans. So from W you can remember the welcome, and G is for go. Welcome and go. Just a way to remember it. Like in the ganglion, in the sympathetic ganglion, the root which is welcoming the axon inside, the one which is allowing the axon to come inside the ganglion, they are the W, that is white ramus communicans. And the one which will leave the ganglion will go through G, go, that is gray ramus communicans. Now there are certain possibilities that we have to look into. But before we look into what are the possibilities, that what are the kind of fibers in present white and the gray ramus communicans and what variations you have in sympathetic chain, we should know a bit about sympathetic chain. Number of sympathetic ganglion is not corresponding to the number of spinal segments that we have. So guys, when we talk about the number of sympathetic ganglion in sympathetic chain, we do have a sympathetic ganglion apart from the chain also, we have a paravertebral ganglion, but I'm talking about the sympathetic ganglion which are present in sympathetic chain. There are approximately 21 to 22 pairs. So we have around 21 to 22 pairs of the sympathetic ganglia, out of which cervical region we have 3 ganglion, the superior cervical, middle cervical and inferior cervical. And usually this inferior cervical ganglion is fused with the first thoracic ganglion to form the stellate ganglion. That's a very, very common finding, that the inferior cervical ganglion and the first thoracic ganglion, they are fused and they form a single ganglion called the stellate ganglion. You must have heard about the stellate ganglion in stellate ganglion block also. Then after that we got a thoracic ganglion. There's a number of thoracic ganglion, it is around 11. In the lumbar region, the lumbar ganglion, they are around 4. And sacral, it's around 4 to 5. There are around 4 to 5 ganglion in the sacral. So that's a number of sympathetic ganglion which are connected by the chain, so called a sympathetic chain here. So one thing is quite clear, that number of sympathetic ganglion in the chain is definitely not corresponding to the number of spinal segment, and it is not even corresponding to the thoracolumbar outflow. Right? Thoracolumbar outflow is from T1 to L2. That means we're talking about 14 nerves, isn't it? 12 thoracic nerve and 2 lumbar nerve. But that doesn't mean we only have the 12 sympathetic chain. We have way more sympathetic ganglion in the chain over there. So what is the purpose of having these many ganglions, and where they will get the fibers from? Let's talk about that here. So as I said, with this sympathetic ganglion, we have some possible scenarios. So I'll use a different diagram to make you understand those, and then we'll have a big recap also in the end. Okay, guys. The scenario number one is that, as we already said, we have the preganglionic sympathetic neuron will start from the lateral horn. So that's a lateral horn nuclei from where the preganglionic sympathetic neuron will begin, and this preganglionic sympathetic neuron will take the ventral route to come out, will go to the distal connection, that is a white ramus communicans, enter the sympathetic chain, and will relay there. Let me just write in short here. This is W, that is white ramus, and this is G, that is gray ramus communicans. So what you're looking at here is these are preganglionic sympathetic neuron. That's a preganglionic sympathetic neuron which is coming and relaying into this sympathetic chain. But remember that through the distal connection, that is through the white ramus communicans. So that means that they are obviously myelinated. These are all myelinated. I'm just writing MY for myelinated. The postganglionic. So first possible scenario is that postganglionic sympathetic neurons, they will go out through gray ramus communicans, join the same spinal nerve, and then will exit through the spinal nerve. As we know, that spinal nerve will further divide into the dorsal and the ventral primary rami. So they will take the route of both dorsal and ventral primary rami, and ultimately going to supply like smooth muscles of blood vessels. They supply the smooth muscles of blood vessel. They do supply the muscles like erector pili muscle, erector pili, and they also supply the sweat gland. So that's one scenario you're looking at. Then where the postganglionic sympathetic neuron is coming out through the gray ramus communicans. So obviously this gray ramus communicans is having the postganglionic sympathetic neuron, which is non-myelinated. That's why we say gray ramus communicans. We do have a non-myelinated axons there, and they are coming out to the same spinal nerve, and they're going to supply the smooth muscles of the blood vessel, the erector pili muscle, and the sweat glands. So that's, guys, that's one possible scenario. And because they're going to supply the smooth muscles, they're going to supply the sweat glands. So obviously this will come under which column? This comes under the general visceral efferent column. We usually talk about these columns in the brainstem when we talk about cranial nerves. We say GVE, GVA, SV, and all that. General visceral efferent. If you remember, general visceral efferent column in the brainstem is the one which is having all parasympathetic nuclei. Edinger-Westphal nucleus, superior salivatory, inferior salivatory nucleus, dorsal nucleus of vagus. Similarly, the GVE column here, the GVE column is represented by these nerves also, which are sympathetic nerve, because they are also going to supply the smooth muscles and the glands. So whether it is brainstem or it's spinal cord, if you see a nerve is going to supply the smooth muscles and glands, then obviously it comes under the GVE column, general visceral efferent column, general visceral efferent. So that is case number one. That is case number one. Now see, what is the second scenario? What is the second case scenario is that, now look at it, using another diagram for this. Once again, from this lateral horn nuclei, we have preganglionic sympathetic neuron coming out through this ventral route. And they will take again this white ramus communicans thing here, that will enter through the white ramus communicans, and imagine without relaying into the sympathetic chain, they are simply coming out, and then they're going to relay in one of the paravertebral ganglion. One of the paravertebral ganglion. You must be knowing about the paravertebral ganglion, like celiac ganglion, aortic-renal ganglion. They are present in relation to the aorta, so we call it paravertebral ganglion. I'll take one example here. Let's say the celiac ganglion. So once again, I can say that white ramus communicans, this is great. White ramus communicans is having preganglionic sympathetic neuron. No question about that. So nothing has changed. This again is a preganglionic sympathetic neuron is there, which is myelinated. This is myelinated, and that is entering into the sympathetic chain through white ramus communicants. But the point is, they are not relaying into the sympathetic chain. They exit the sympathetic chain, and they will find their own ganglion close to the vista or close to the aorta. Those are paravertebral ganglion. Like one example is a celiac ganglion. So what I'm looking at, that even though these nerve fibers, they are coming out of the sympathetic chain, but they're still preganglionic. So it doesn't mean that if you're looking at a nerve fiber coming out of sympathetic chain, then it is always postganglionic. No, it's not necessary. This one is still which? It is still preganglionic. It is preganglionic sympathetic neuron that you're looking at coming out of sympathetic chain, and they are the one which forms the splanchnic nerves. They form the splanchnic nerves. You all must have heard of these splanchnic nerves. The greater splanchnic, lesser splanchnic, least splanchnic nerve. So when you look at these splanchnic nerves coming out from this thoracic region of the sympathetic chain, they are coming out of the sympathetic chain directly. So this gives an indication, okay, they must be postganglionic, but they're not. They're still preganglionic sympathetic neurons, and they pierce the crest of the diaphragm, they reach the abdominal region, and they find their own ganglion in that region. That is like celiac or aortic-renal ganglion. And from that ganglion, the postganglionic fibers will begin, and they are the one which are going to supply the vessel, let's say the stomach or the aorta or whatever. So that's the second scenario you're looking at, that you may have a fibers running in the white ramus communicants which relay into the sympathetic chain. You may have a fibers running from the white ramus communicants which exit the sympathetic chain and relay in the ganglion which are like away from them. They are paravertebral ganglion, and then postganglionic fibers will reach the viscera. Third scenario. But before I discuss this third scenario with you, now we are only talking about the efferent guys. We're talking about that the nerve fibers are going out. What about afferent fibers? Now we'll be having the two types of sensation coming into the spinal nerve. One coming from the body wall, that's general somatic sensation, like general somatic afferent, and sensation from the viscera also, general visceral afferent, the general sensation from the viscera. If the sensation is coming from the somatic structures, if it is coming from the somatic structures, that is from the skin or muscle, then they have nothing to do with the ganglion. What I'm saying is, if let's say I'm talking about the general sensation, just an example, general sensation from skin. Now that general sensation from skin, which could be pain also, that general sensation from the skin, which comes under GSA column, general somatic afferent. It's a general sensation coming from body wall, so it comes under GSA, general somatic afferent. Now what you see, that these sensations will enter into the spinal nerve, have nothing to do with the white and the gray ramus communicants, will go to the dorsal root ganglia where they have their pseudo-unipolar neuron, will use the dorsal root and enter into the dorsal horn of the spinal cord. Just drawing these arrows so that you remember that it is the afferent I'm talking about, general somatic afferent. The sensation coming from the somatic structure could be skin, dermis, muscle. So all those sensations coming in, they have nothing to do with the white and the gray ramus communicants. So we can leave it up. So So we do not have any GSA fibers in the sympathetic chain. But what about those sensations which are coming from the viscera, like general visceral afferent, general sensation from the, let's say, stomach, like the feeling of distension of stomach, or the pain fibers coming from the heart. So they are the one, because they're coming from the visceral organ, so they have to go through the sympathetic chain. So GSA has nothing to do with the sympathetic chain, but GVA will have a say to the sympathetic chain. So let us understand what GVA will do. Let me take another diagram here. Now we're talking about the GVA fiber, guys. That is general visceral afferent. That is general sensation from viscera. Now if I talk about the general sensation from viscera, that obviously comes under the GVA. It comes under this GVA, general visceral afferent. Now these GVA fibers, if I see it in this direction, they will, what you're going to see is that they will enter into the sympathetic chain actually through gray ramus communicants, will use the white ramus communicants, then use this spinal nerve, have their pseudo-unipolar neuron dorsal root ganglia, and ultimately going to relay into the dorsal horn of the spinal cord. So what you see here this time, although these fibers are not relaying into what? They are not relaying into the sympathetic chain, but they are connected to sympathetic chain. So if the sensation is coming from the somatic structure, it is simply bypassing the ganglion and going directly into the dorsal horn. But if it is coming from the viscera, that will enter through the gray ramus communicants. Look at that. Enters through the gray ramus communicants, and then those fibers that enter toward the spinal cord through the white ramus communicants will have their pseudo-unipolar neuron present in the dorsal root ganglia and ultimately goes into the dorsal horn of the spinal cord. So I can say that GVA fibers are the one which are having a connection to the sympathetic chain. So till now what we saw, that GVE and GVA, these are the two types of fibers that you expect to see in the sympathetic chain. GVE and GVA are the two types of fibers that you expect to see in the sympathetic chain. Okay. Now another thing to understand here, that these GVA fibers, the one which are carrying these are actually non-myelinated fibers. These are non-myelinated fibers. Like pain fibers are carried by the C fibers, that is, they are non-myelinated fibers. So I can see these non-myelinated fibers are passing from where also? They are passing from the white ramus communicants. And that is why we said in the beginning that white ramus communicants predominantly it is having the myelinated axons, but it is also having some non-myelinated axons like the one which are coming from the viscera carrying the general sensation from the viscera. That is another possible scenario for the white and the gray ramus communicants. And finally guys, one more thing. Now sympathetic chain, what's the advantage of having a chain? Why can't we simply have the sympathetic ganglion present along the T1, T2, T3? But they're all connected to each other. They are connected to each other because the preganglionic nerve, when it enters the sympathetic chain, it can always go up and down, and it can come out from a different level also. Like cervical region of the spinal cord is not sympathetic. Sacral region of spinal cord or the lumbar region, lower lumbar region of spinal cord is not sympathetic. But we still need sympathetic supply in those regions. So these preganglionic sympathetic neuron can enter the sympathetic chain, and then they can ascend upward and they can descend downward and can come out from a different level. So one thing which I want you to understand from this, now look at this picture. This is the one which is shown with the sympathetic chain. So I'm looking at more than one ganglion here. So what I'm talking about here guys, there is a possibility that the fibers, the preganglionic sympathetic neurons, once again coming out from this ventral root, same story again, they will enter through this white ramus communicants into the sympathetic chain. There we go, they will relay here. Once again, that's a white ramus communicants. One chance was that they will come out of the gray ramus communicants, and they might, and the post-ganglion fibers will come out. Now that was one scenario, that they will go like this and will go through this gray ramus communicants. But as I said, there also is a chance that this preganglionic sympathetic neurons, few of these preganglionic sympathetic neurons, instead of relaying there, they will continue their journey in the sympathetic chain and reach in the ganglion which is above. Let's say superior cervical ganglion. And then from the superior cervical ganglion, if I just take an example, it's an example only, let us say this is the superior cervical ganglion here, just writing SCG, superior cervical ganglion. From this superior cervical ganglion, the post-ganglionic sympathetic neuron will again come out, and then the same story will go out and supply the smooth muscles and glands. And obviously to come out, which ramus is needed? This has to be the gray ramus communicants. Now this tells me one very, very important point to understand here, that guys, when you say white ramus communicants cannot be present everywhere. White ramus communicants is the point from where the preganglionic sympathetic nerve enters inside. Get the point? So that means you cannot have the preganglionic sympathetic nerve everywhere. We only have them in T1 to L2 region. So that is why white ramus communicants, this white ramus communicants is present only between T1 to L2 region. But gray ramus communicants is the one which is the exit from the sympathetic chain. So wherever you have a sympathetic chain, you obviously will have an exit pathway there. Entry pathway is only from T1 to L2, but exit pathway is present everywhere because the post-ganglionic fiber has to go out and supply the effector organ. That's why the gray ramus communicants is present throughout the extent. They're present throughout the extent, throughout the sympathetic chain they're present. So we have gray ramus communicants everywhere, but white ramus communicants are present only in T1 to L2 region where the preganglionic nerve has to enter inside. So this is a short discussion about that, what exactly the white and the gray ramus communicants is and what type of fibers are seen inside. Let me have a very quick recap before we wrap it up. As we said, it's just the first time we're doing this live session here, so I just took a very small topic, and if it goes fine, if you like it, we can have more of these sessions in the future as well. So there we go guys, let's have a very quick recap here for the people who joined late. So what we're looking at here, we're looking at a section of the spinal cord where you can see the dorsal root and the ventral root. Let me just keep highlighting, that's the dorsal and the ventral root. And we do have this lateral horn nuclei present in the region where we have cell bodies of sympathetic or parasympathetic neurons. Talking about sympathetic outflow comes from T1 to L2. So we are looking at these lateral horn nuclei in the region of first thoracic nerve, then the second lumbar nerve, it could be L3 also. What you see, the spinal nerve is connected to the sympathetic chain or the sympathetic ganglion by two. The distal one is called the white ramus communicants and the proximal one is called the gray ramus communicants. The white, because of the myelination, we call it white ramus communicants, but it is predominantly myelinated, but it's not that it is only having the myelinated axon, it is having the non-myelinated axons also. Gray ramus communicants is essentially having the non-myelinated axons. The first possible scenario that we saw here was that the fibers are coming out of this ventral root and they enter into the sympathetic chain through which one? Through the white ramus communicants, relay in the sympathetic chain, and non-myelinated post-ganglionic sympathetic neurons comes out of gray ramus communicants, use the same spinal nerve and ultimately goes to supply the smooth muscles of the blood vessel, erectropylae muscle or the sweat glands. Second possible scenario is then where you see the preganglionic sympathetic neuron again entering through what? White ramus communicants, and instead of relaying in the sympathetic chain, the fibers are coming out directly of the sympathetic ganglion, and these nerves are preganglionic sympathetic neurons. Although they are coming out of the chain, but still they are preganglionic sympathetic neurons, and these nerves are specifically called as the splanchnic nerves. You must have read about the splanchnic nerves in thorax also, the greater splanchnic, lesser splanchnic, least splanchnic nerves. And these splanchnic nerves, they will actually go through the diaphragm, they usually pierce the crest of the diaphragm and reach the abdominal region, where they go and relay into the paravertebral ganglion, like celiac, aortic-renal ganglion. So they have that. So sympathetic chain is not the relay center for them. These paravertebral ganglion is the relay center, and from there, the post-ganglionic fiber will reach the stomach. There's one exception which I can tell you here. There's one wonderful exception here. Those preganglionic sympathetic neurons, which have to relay in the adrenal medulla, they will bypass the sympathetic chain also and celiac ganglion also. Now, isn't that amazing here? So what I'm trying to say here, if we're done with this, or if I can afford to. So what I'm saying is, those preganglionic neurons, I'm talking about the adrenal medulla. That's a specialty in the adrenal medulla. Let's say here's the celiac ganglion. That's the celiac ganglion, and let's say this here is the adrenal medulla. That's the adrenal medulla. So these fibers, they come out of the sympathetic chain without relaying, and they come out of the celiac ganglion also without relaying, and they ultimately go and relay in the adrenal medulla only. So those preganglionic sympathetic neurons, which are specifically for the adrenal medulla, that's one special, one exception that you should remember, that they will come out of the white ramus communicants into the sympathetic chain, no relay there, through the celiac ganglion, no relay there, and they ultimately relay into the ganglions present in the adrenal medulla itself. The next case we talk about is that GSA, general somatic affect, any general sensation from the body wall, from the skin, from the muscle, that will go and have no connection with the white or the grey ramus communicant. So as you can see, the fibers are going directly to the dorsal root, and they're going and relaying into the dorsal horn of the spinal cord. So GSA has nothing to do with the sympathetic chain. Another possible scenario is that when GVA fibers, that is the one which are getting the general sensation from the viscera, the non-myelinated GVA fibers, they are the one which are entering through the grey ramus communicant. See, you can say they're entering into it, or you can see it in this way, that they are actually entering through white ramus and going out through grey ramus. But because we're talking about sensory, so it's always good to say like that they are entering through grey ramus communicants, and then they will exit through the white ramus communicants to go back to the dorsal root this time, once again having their pseudo-unipolar neurons in the dorsal root ganglia, and finally into the. So that means sympathetic chain is also having, apart from GVE, they're also having GVA type of fibers. GVA type, general sensation from the viscera, non-myelinated exons. And finally, we said that also is a possibility that the preganglionic sympathetic neuron will come through this ventral root, will go into the white ramus communicants, will continue the journey into the sympathetic chain, will go above or below, depends where it has to reach, and might relay into any respective ganglion, like superior cervical or middle cervical, and then from there, the post-ganglionic fibers will come out through the grey ramus communicants and supply the effector organ, which tells me that the grey ramus communicants will be present everywhere throughout the sympathetic chain, but white ramus communicants is only present in the thoracolumbar region and nowhere else. Right? And that is why we say that injury to T1 region, guys, when we have the injury to the T1 root, why there is a Horner syndrome? The post-ganglionic fibers to supply the muscles like the dilator pupillae or the sweat glands of the face, they are all supplied by the superior cervical ganglion. Injury is not to superior cervical ganglion. Injury is to what? T1. In Horner syndrome, let's say the injury is to T1 root, but still we can have a sympathetic loss on face because the preganglionic fibers have to come from T1 only. There is no nerve above T1, there is no spinal segment above T1 which will give off the preganglionic sympathetic neurons. That's why in case when we read about the injuries of brachial plexus, in the club case fallacy, when the injury is to the T1 root, it can also lead to the Horner syndrome. That means the preganglionic sympathetic neuron, which are supposed to supply the face, are also disrupted. So guys, this is about the discussion on the white and the grey ramus communicants. I hope I'm able to make you understand the difference between the two. And it's a very small but wonderful topic, and there could be a lot of MCQs which can be framed from this one. Hello everyone, and welcome to this discussion regarding anatomical insight of conus medullaris syndrome and cauda equina syndrome. Well, people find this topic difficult to understand because of lack of knowledge of the spinal cord and the vertebral column in relation to each other. When we look at the lower part of the spinal cord and the extent of the vertebral column, they are obviously not corresponding because of the differential growth. Let us first look into the anatomical feature of the conus medullaris and the cauda equina, and from there on we can talk about the syndromes. So let us say we are looking at a sagittal section of a spine in the lower part of the vertebral column, I should say. So these are the lower lumbar vertebrae there. You can see the lower lumbar vertebrae can be seen here, and then we have the sacrum and the coccygeal vertebrae can be seen, and this is the sagittal section as we're talking about. The spinal cord in adult, it extends till the lower border of L1 vertebrae. The extension of spinal cord is till the lower border of L1 vertebrae. So let's imagine that over there is a spinal cord, and this is the end of the spinal cord, which is corresponding to this first lumbar vertebrae, lower border. It can go to the L2 also, but usually we say to the lower border of L1. Now I have marked some segments in that region. Look at the segment which I'm highlighting here with the red color. Now these segments are the lumbar segments. So the nerve coming out from here are the lumbar nerves. But the issue is that lumbar nerves will come out from there, but the lumbar intervertebral foramen are present now below the level of the spinal cord. Therefore, the spinal nerve has to come down and then emerge out from those intervertebral foramen. Below that, we have a sacral segment. So obviously the sacral nerves will come out from here. So look at this green thing here, these are sacral segments here. So the 5 sacral nerve will come out from there. And again, they have to go even further downward to come out from the intervertebral foramen related to the sacral bone. And same is with the coccygeal. The coccygeal nerve will need to come out all the way from the foramen which is present in the caudal part of the vertebral column. So if you see the relation of the spinal cord segment and the vertebral column and how the nerves are coming out, this animation is going to help you with this. So you can see the first lumbar nerve is coming out from the intervertebral foramen between L1 and L2. Same is second lumbar, third lumbar, fourth, and the fifth lumbar nerves are coming out. And as you can see, the more they're coming down and coming out of their respective intervertebral foramen, they're forming a tuft of nerve in the lower part. The sacral nerves has to go even further downward. So you can see the first sacral nerve there. Here's the second, third, which is seen in the spinal cord and the vertebral column. Obviously, vertebral column being longer, so intervertebral foramen are present below the respective segment, and the nerve has to come down to come out from the intervertebral foramen. Now, this portion of the spinal cord, this whole thing is a lumbar enlargement, but this tapering end of the spinal cord, where the sacral and coccygeal nerves are coming out, the one which is marked with the green here, is what we call as a conus medullaris. This is called as a conus medullaris, and the vertebral level of conus medullaris is the first and second lumbar vertebral. That is a vertebral level. But yes, the segment, the nerves which are coming out from conus medullaris are the sacral nerve and the coccygeal nerve. So that's conus medullaris, and S1 and to the coccygeal, what I've written over there is not the vertebral level, is the spinal segment we're talking about, the nerves which are emerging from the conus one. And below that lower border of L1, when you look at all the nerves below L1 here, all these nerves are present below the spinal cord, and they have to come out from the respective intervertebral foramen. So they form a horse tail-like structure, and that is what we call as the cauda equina. That is the cauda equina. So when we talk about the segments or the nerve related to cauda equina, it is from L2 again till the coccygeal. So cauda equina is about L2 to coccygeal. So be careful about this part when the question is about the vertebral level. So vertebral level is like L1 and L2 is the vertebral level for the conus medullaris, and for the cauda equina, below that everything is a vertebral level for the cauda equina. But that is a vertebral level. The spinal segment or the spinal nerves related to it, the conus medullaris is giving off the nerve which are the sacral nerves and the coccygeal nerve. Whereas we have more nerve related to cauda equina because that also involves a lumbar nerve. From L2 to coccygeal nerve, all these nerves they comes under cauda equina. So by looking at this this picture, we can make out that if there is an injury to conus medullaris, this is going to be more of the central nervous system type of injury. So the injury will be here, so that will be more like a CNS type of injury, more of a upper motor neuron lesion kind of thing. Whereas in cauda equina, it is clearly the injury to the nerves here. So the symptoms or the features that you will see are more corresponding to the peripheral nerve type of injury. So this is a little bit about the anatomy of the conus medullaris and cauda equina, and based on this, we can discuss the features of the two syndromes. But again, before switching to the syndrome, we first want to understand certain basics so that we can apply on both the syndrome and how they will be seen differently. Like the first thing that we should know about the ankle jerk and the knee jerk, we all learned about these deep tendon reflexes. The knee jerk root value is L3 and L4, and ankle jerk root value is S1 and S2. Now, why it is important to know these two root value here? Because again, if you look at these nerves which are responsible for the ankle or the knee reflex, now which reflex is going to be affected in the conus medullaris syndrome and cauda equina syndrome can be understood just by looking at the root value only. Now here, S1 and S2 is a part of both conus medullaris as well as the cauda equina. That means ankle jerk reflex will be lost or will be affected in case of both cauda equina as well as conus medullaris syndrome. But knee jerk will be spared in case of conus medullaris because it is L3 and L4. Lumbar nerves are involved in it, and conus is all about sacral and coccygeal nerve. So I repeat again, conus medullaris syndrome, we have ankle jerk that is being affected, but in case of the cauda equina syndrome, both knee jerk as well as ankle jerk reflex will be affected. Another important thing here, if you look at the cutaneous innervation, if you look at the cutaneous innervation in the perineal region around the anal canal, around the inner aspect of thigh here, this region here is called the saddle region. Now the saddle or the perianal innervation, the cutaneous nerve supplying this saddle or the perianal region, we call it saddle region because if you look at this, it is including the perianal portion, the inner aspect of thigh as well. So if it is a conus medullaris type of syndrome in which it is an injury precisely to the sacral segment, so we have more of the sacral involvement, and that will be perianal anesthesia because S4, S5 is supplying around the anal canal. But in case of the cauda equina syndrome, obviously more nerves are involved in that. So lower lumbar nerves are also involved in that region, and that's why the sensory loss will be seen along with the perianal region. You will see it along the medial aspect of thigh, and because of the higher lumbar nerve involvement, also it can be seen extending to the pubic region also, to the glands and the clitoris as well. You may see the numbness in that region as well. So saddle or perianal anesthesia will be seen in both the cases. But if I say about the conus medullaris syndrome, it is more localized to the anal region, to the perianal region. The next we need to understand here is about the bulbocavernous reflex, which is also called as a bulbospongious reflex. Well, this reflex is a well-known somatic reflex which is used to gain the information about the state of the caudal part of or the sacral region of the spinal cord. The afferent of the bulbocavernous reflex as well as the efferent of the bulbocavernous reflex, which is through the pudendal nerve supplying the external anal sphincter. So in both the cases, you can see it's the pudendal nerve forming the afferent and the efferent lip. So the root value here again being S2, S3 and S4. Now if it is a cauda equina type of syndrome, then obviously the nerve is involved here. If the nerve is involved, obviously the innervation to the external anal sphincter or the sensory innervation which is going to the dorsal horn will be lost. So there will be absent bulbocavernous reflex in case of the cauda equina. In case of conus medullaris syndrome, initially this reflex will be absent because of the spinal shock, but returning of the bulbocavernous reflex is an indication that the spinal cord has come out of the spinal shock. So once the spinal cord comes out of the spinal shock, you will see there is a recovery of the bulbocavernous reflex in that case. Now talking more about this S2, S3 and S4 segment, as we said, the sacral segment involvement precisely in case of conus medullaris syndrome, the S2, S3, S4 segment will be involved, which is giving rise to the somatic nerve as well as the splanchnic nerves. Now the pelvic splanchnic nerves which are coming from S2, S3, S4 are going to supply the smooth muscles of the bladder, the detrusor muscle, and these detrusor muscles are obviously responsible for the emptying of the bladder. On the other hand, S2, S3, S4 is seen in the pudendal nerve as well, which is supplying the area of structures. Like if I look at the pudendal nerve, one of the innervation of the pudendal nerve through its perineal branch is to the sphincter urethrae. So if S2, S3, S4 segments are involved, then obviously detrusor muscle and urethral sphincter are not working. Detrusor muscle inability at this point is not allowing the urine to flow out, so there will be urinary retention, and urethral sphincter atonicity will allow the incontinence. So there will be an overflow urinary incontinence because of the detrusor muscle involvement as well as urethral sphincter. Pudendal nerve through its inferior rectal branch is a branch of the pudendal nerve which goes through ischiorectal fossa called as inferior rectal nerve, and that supplies the external anal sphincter. So the atonicity of the external anal sphincter will lead to the fecal incontinence. And also we have a deep perineal branches of pudendal nerve which are going to supply the muscle. extending to the pubic region also, to the glands and the clitoris as well. You may see the numbness of both conus medullaris as well as the cauda equina. That means ankle jerk reflex will be lost or will be affected in case of both cauda equina as well as conus medullaris syndrome. But knee jerk will be spared in case of conus medullaris because it is L3 and L4. Lumbar nerves are involved in it, and conus is all about sacral and coccygeal nerve. So I repeat again, conus medullaris syndrome, we have ankle jerk that is being affected. But in case of the cauda equina syndrome, both knee jerk as well as ankle jerk reflex will be affected. Another important thing here, if you look at the cutaneous innervation, if you look at the cutaneous innervation in the perineal region around the anal canal, another inner aspect of thigh here, this region here is called the saddle region. Now the saddle or the perianal innervation, the cutaneous nerve supplying this saddle or the perianal region, we call it saddle region because if you look at this, it is including the perianal portion, the inner aspect of thigh as well. So if it is a conus medullaris type of syndrome in which it is an injury precisely to the sacral segment, so we have more of the sacral involvement, and that will be perianal anesthesia because S4, S5 is supplying around the anal canal. But in case of the cauda equina syndrome, obviously more nerves are involved in that. So lumbar nerves are lower lumbar nerves are also involved in that region, and that's why the sensory loss will be seen along with the perianal region. You'll see it along the medial aspect of thigh, and because of the higher lumbar nerve involvement, also it can be seen extending to the pubic region also, to the glands. This saddle or the perianal region, we call it saddle region because if you look at this, it is including the perianal portion, the inner aspect of thigh as well. So if it is a conus medullaris type of syndrome in which it is an injury precisely to the sacral segment, so we have more of the sacral involvement, and that will be perianal anesthesia because S4, S5 is supplying around the anal canal. But in case of the cauda equina syndrome, obviously more nerves are in that. So lumbar nerves are lower lumbar nerves are also involved in that region, and that's why the sensory loss will be seen along with the perianal region. You'll see it along the medial aspect of thigh, and because of the higher lumbar nerve involvement, also it can be seen extending to the pubic region also, to the glands and the clitoris as well. You may see the numbness in that region as well. So saddle or perianal anesthesia will be seen in both the cases. But if I say about the conus medullaris syndrome, it is more localized to the anal region, to the perianal pubic region also, to the glands and the clitoris as well. You may see the numbness in that region as well. So saddle or perianal anesthesia will be seen in both the cases. But if I say about the conus medullaris syndrome, it is more localized to the anal region, to the perianal region. The next we need to understand here is about the bulbocavernous reflex, which is also called as the bulbospongious reflex. Well, this reflex is a well-known somatic reflex which is used to gain the information about the state of the caudal part of the or the sacral region of the spinal cord. The afferent of the bulbocavernous reflex as well as the efferent of the bulbocavernous reflex, which is through the pudendal nerve supplying the external anal sphincter. So in both the cases, you can see it's the pudendal nerve forming the afferent and the efferent loop. So the root value here again being S2, S3 and S4. Which is through the pudendal nerve supplying the external anal sphincter. So in both the cases, you can see it's the pudendal nerve forming the afferent and the efferent loop. So the root value here again being S2, S3 and S4. Now if it is a cauda equina type of syndrome, then obviously the nerve is involved here. If the nerve is involved, obviously the innervation to the external anal sphincter or the sensory innervation which is going to the dorsal horn will be lost. So there will be absent bulbocavernous reflex in case of the cauda equina. In case of conus medullaris syndrome, initially this reflex will be absent because of the spinal shock. But returning of the bulbocavernous reflex is an indication that the spinal cord has come out of the spinal shock. So once the spinal cord comes out of the spinal shock, you will see there is a recovery of the bulbocavernous reflex in that case. Now talking more about this S2, S3 and S4 segment. And S4 segment. S2, S3 and S4. Now if it is a cauda equina type of syndrome, it is more localized to the anal region, to the perianal region. The next we need to understand here is about the bulbocavernous reflex, which is also called as the bulbospongious reflex. Well, this reflex is a well-known somatic reflex which is used to gain the information about the state of the caudal part of the or the sacral region of the spinal cord. The afferent of the bulbocavernous reflex as well as the efferent of the bulbocavernous reflex, which is through the pudendal nerve supplying the external anal sphincter. So in both the cases, you can see it's the pudendal nerve forming the afferent and the efferent loop. So the root value here again being S2, S3 and S4. Now if it is a cauda equina type of syndrome, then obviously the nerve is involved here. If the nerve is involved, obviously the innervation to the external anal sphincter or the sensory innervation which is going to the dorsal horn will be lost. So there will be absent bulbocavernous reflex in case of the cauda equina. In case of conus medullaris syndrome, initially this reflex will be absent because of the spinal shock. But returning of the bulbocavernous reflex is an indication that the spinal cord has come out of the spinal shock. So once the spinal cord comes out of the spinal shock, you will see there is a recovery of the bulbocavernous reflex in that case. Now talking more about this S2, S3 and S4 segment. As we said, the sacral segment involvement precisely in case of conus medullaris syndrome, the S2, S3, S4 segment will be involved, which is giving rise to the somatic nerve as well as the splanchnic nerves. Now the pelvic splanchnic nerves which are coming from S2, S3, S4 are going to supply the smooth muscles of the bladder, the detrosor muscle, and these detrosor muscles are obviously responsible for the emptying of the bladder. On the other hand, S2, S3, S4 is seen in the pudendal nerve as well, which is supplying the area of structures. Like if I look at the pudendal nerve, one of the innervation of the pudendal nerve through its perineal branch is to the sphincter urethrae. So if S2, S3, S4 segments are involved, then obviously detrosor muscle and urethral sphincter are not working. Detrosor muscle inability at this point is not allowing the urine to flow out, so there will be urinary retention. And urethral sphincter atonicity will allow the incontinence. So there will be an overflow urinary incontinence because of the detrosor muscle involvement as well as urethral sphincter. Pudendal nerve through its inferior rectal branch. There's a branch of the pudendal nerve which goes through ischial rectal fossa called as inferior rectal nerve, and that supplies the external anal sphincter. So the atonicity of the external anal sphincter will lead to the fecal incontinence. And also we have a deep perineal branches of perineal nerve which are going to supply the muscle that is bulbospongiosus and ischiocavernosus, the muscle which are present in the superficial perineal pouch, and these muscles are important for maintaining erection. When these muscles contract, they obstruct the venous blood flow coming from the superficial vein of the penis. So if the perineal nerve is affected, the bulbospongiosus and ischiocavernosus will not contract, they will not be able to obstruct the venous blood flow, and that will lead to impotence. Therefore, involvement of the S2, S3, S4 segment not only will give you the symptoms of the pelvic splanchnic nerve like uterosal muscle involvement, also the perineal nerve, the somatic symptoms will be seen, which involves the incontinence. There will be a fecal incontinence, and impotency will be seen in case of conus medullaris syndrome. Now, knowing about all these anatomical aspect of the conus as well as the chorda equina, let us summarize the features of both the syndromes. So let's see it in a tabular man. So on one side we have a conus medullaris and on the other side the chorda equina syndrome. Let's start first with the vertebral level. Now if you remember, not the spinal, it's a vertebral level. At what vertebral level we saw the conus medullaris? That was the L1 and L2. The spinal cord was ending at the lower border of L1, or let's say till the L2 level. And chorda equina is extending all the way from L2 to the coccygeal or sacral region. So L1 to L2 vertebrae, that is vertebral extent of the conus medullaris, and then we talk chorda equina, that is from L2 to the sacral vertebrae. What spinal nerves are involved? If you talk about the spinal segment involvement, then again spinal segment and conus medullaris was precisely the sacral region of the spinal cord along with coccygeal. So S1 to coccygeal nerves or coccygeal segment will be involved in conus medullaris, and in chorda equina syndrome, now starting from L2 to coccygeal nerve. So more extended nerve involvement will be seen in the chorda equina, more of a peripheral type. The next thing is type only. Conus medullaris injury is directly to the spinal cord, so it is more like a central nervous system type of lesion, and chorda equina syndrome, it's a peripheral nervous system type of lesion. Spread or onset, if you see, in conus medullaris it is sudden, but it is symmetrical. If the injury is to the spinal cord, there are very good chances the effect will be bilateral. It could be unilateral, but usually it is bilateral. But in chorda equina syndrome, the few nerves will be involved and few might be spared. We have a dorsal and ventral root, everything is present in that thecal sac. So there might be sparing of some nerves, and that's why it is more asymmetrical type of features we will see in the chorda equina syndrome. DTR, deep tendon reflexes. As we already discussed in case of the conus medullaris, because of the sacral involvement, so the only deep tendon reflex which will be affected here is the ankle. But in case of chorda equina, more number of nerves, peripheral nerves are involved. So lumbar as well as sacral nerve involvement will lead to the loss of ankle as well as knee reflex. So both ankle and knee reflex will be affected. Bulbocavernous reflex, we discussed that as well. Bulbocavernous reflex in case of conus medullaris syndrome, it may be preserved, and as I said, it could be a sign of the recovery of the spinal cord from spinal shock. And in chorda equina syndrome, it will be lost because the peripheral nerve is gone. There is no nerve to supply that respective muscle. What about the motor part? Now this is, we got to understand here guys, motor innervation, if you look at the muscles of the lower limb, majority of the muscles of the lower limb are supplied by the lumbar and the sacral plexus. So in case of chorda equina syndrome, because we have the nerve involvement starting all the way from L2 to the coccygeal nerve, so obviously the more muscles will be affected in chorda equina syndrome, and this being a lower motor neuron type of lesion, it will lead to the flaccid paralysis. So we have a more extended type of motor loss in case of chorda equina, but because we have again specific sacral segments are involved, so there will be paralysis in lower limb seen because of the conus medullaris, but that will be a distal paralysis because the distal muscles are supplied by the sacral segment. So it is less marked and distal paralysis of the lower limb in case of conus medullaris, where in case of chorda equina it is more marked. There will be atrophy of the muscles will be seen, and the flaccid type of paralysis will be seen. Sphincter, this also we discussed in case for sphincter, because of the involvement of the nerves in the sacral S2, S3, S4 region, the splanchnic nerve as well as the perineal nerve, there will be urinary retention, the overflow urinary incontinence, and fecal incontinence will be seen in case of conus medullaris, which can be seen in case of chorda equina syndrome as well, but that is little late when you see the course of this injury. So urinary retention is present in case of chorda equina also, may be present in case of chorda equina, but the presentation will come little later. Sensory deficit, we said if it is a conus medullaris, so it will be more of a sensory loss in the perianal region, which is supplied by the sacral nerve, the lower sacral nerves, S4 and S5. So that is more of a numbness localized to the perianal region. Here in chorda equina syndrome, it's more of the saddle type of anesthesia which is involving the perianal region, but the medial aspect of thigh will also be involved, and because of the lumbar nerve involvement, you might see the sensory loss extending to the pubic region as well. And finally, impotence in case of conus medullaris, again because of involvement of the bulbocavernosus and the bulbospongiosus and ischiocavernosus muscle, the impotence will be seen in case of conus medullaris syndrome, which can be seen in case of chorda equina if those particular nerves are involved, but less frequent when you compare with the conus medullaris. So these are some differences between the conus and the chorda equina. I hope you are able to understand and correlate them with the anatomical part. And if you find this video interesting, please leave your comments and your doubts as well. Hello everyone, and welcome back to this third video, which is in the series of the discussion regarding the cadaveric images. Today we are taking a very, very important topic here, and that is neuroanatomy. We'll be dealing with the sections of the brain, but before going to the sections, let me tell you that what our approach will be in these coming pictures. First, we'll be looking at the ventral aspect of the brainstem. As you can see here, it's a picture of the ventral aspect of the brainstem, and you can see the inferior aspect of the cerebrum as well. And we'll see what blood vessels can easily be marked there, the contribution of from the circle of Willis. We'll talk about the interpeduncular fossa, the boundaries, the contents there. Then we'll turn the brainstem, and we'll look at the dorsal aspect of the brainstem. The dorsal aspect of the brainstem will be seen by removing the cerebellum. And once you remove the cerebellum, that means you're exposing the fourth ventricle. So basically, our discussion from the dorsal aspect of brainstem will be on the floor of fourth ventricle and the boundaries of the fourth ventricle as well. Once we're done with this ventral and dorsal aspect, then we will start with the sections of the brain. We'll start with the transverse section. We'll see the corpus callosum, how the fibers are spreading, the internal capsule and the lentiform nucleus, etc. Then we'll also understand the transverse section at a different level. I mean, one ideal transverse section we'll take in which we can appreciate most of the important nuclei, and then we'll discuss a transverse section of the cerebrum slightly from a lower level so that you can appreciate few more structures which cannot be seen at all level simultaneously. We'll also be looking at the coronal section. In the coronal section, we'll be discussing the floor of, in fact, not only floor, the boundaries of the lateral ventricle. The lateral ventricle can very clearly be seen from the coronal section, and we'll be taking a section from the mid of the cerebrum, so somewhere from the body of the lateral ventricle. And finally, we'll be taking a sagittal section in which we'll appreciate the corpus callosum again, the different type of commissural fibers, and also boundaries of the third ventricle. So let's get on with this. So first image that you're looking at here is the picture showing the ventral aspect of the brainstem and the cerebrum as well. I'll be using this picture twice. First, in this image, guys, let us identify the important blood vessels here. So starting with the posterior circulation, now you can see this artery here is the vertebral artery. Again, I'll be giving the soft copies of these images, so just let me mark them in short. So that's the two vertebral artery you're looking at. As we know, the vertebral artery is a branch from the first part of subclavian, and these vertebral artery, after entering through foramen magnum, they meet in front of the upper part of the medulla oblongata itself. A basic tendency is that basilar artery is running in front of the pons. That is fine, but that doesn't mean basilar artery starts in front of the pons only. The formation of basilar artery is in front of the medulla oblongata. Look at that, that's medulla here, and that's a basilar artery formed in the upper part, in front of the upper part of the medulla itself. So this here is the basilar artery here. The numerous branches from the vertebral artery. Vertebral artery is having a first, second, third, and fourth part. This is the intracranial part or the fourth part of vertebral artery, and the branches given off here are like anterior spinal artery, posterior spinal artery. We have medullary branches, but see, out of all those, the one that we can appreciate here clearly is this one. This is posterior inferior cerebellar artery. I'm sure you've all read about this artery. We read about this artery in the Wallenberg syndrome also. It's a posterior inferior cerebellar artery, and it is the most tortuous artery in the human body, the posterior inferior cerebellum. So that's one major branch we can appreciate in this picture from the vertebral artery coming up. Once the basilar artery is formed, in the lower part, the basilar artery is giving off this another important branch which you can see here, that is anterior inferior cerebellar artery. Anterior inferior cerebellar artery as a variation can also arise from vertebral artery, but usually it is a branch of the basilar artery. And one information which I should give you here itself, that it's the anterior inferior cerebellar artery. In most of the cases, it also gives off the labyrinthine artery. It also gives off the labyrinthine artery. And at most of the places it is mentioned that labyrinthine artery comes from the basilar artery, which is true. But most commonly it's a branch of anterior inferior cerebellar. It may come from basilar also. So if you're looking for a artery coming from a major artery coming from lower part of basilar artery or the initial part of basilar artery, that is anterior inferior cerebellum. Moving up in this picture, the basilar artery, it divides into the two terminal branches. Let me just enlarge this picture a bit more. Now look at this. This is a very prominent terminal branch of the basilar artery, guys. This here is the posterior cerebral artery. Just before the termination into the two posterior cerebral artery, another important artery that you can notice here is the superior cerebellar artery. That's a superior cerebellar artery. So that cerebellum is supplied by three major arteries. One is superior cerebellar artery, which is seen in the upper part of the basilar, and the two are inferior. One is anterior inferior, one is posterior inferior. Anterior inferior cerebellar branch of basilar, and posterior inferior cerebellar is a branch of vertebral. And what another important thing to note about this posterior cerebral artery and superior cerebellar artery is that between these two arteries, the two important nerves can be seen coming out here. Now you can see this nerve, guys. This is the third nerve here. The third cranial nerve can be seen. And look at this, the thinnest cranial nerve, this one, that is a fourth cranial nerve. I hope you can appreciate that. The third nerve and the fourth nerve. Third nerve is coming from interpedicular fossa, which we'll discuss next. And fourth is the only nerve coming from the dorsal aspect of brainstem. But that means one is, both the nerves are actually winding around the cerebral peduncle. When they do so, they emerge out between the two arteries, that is the posterior cerebral artery and superior cerebellar artery. This is about the posterior circulation. These are branches from the posterior circulation which we can easily appreciate in any section. And because these are main arteries here, the anterior inferior, posterior inferior. Moving above, this comes the anterior circulation. That is the anterior circulation, which is all about the branches of internal carotid. So guys, this here is the internal carotid artery. That's a trunk of the internal carotid artery. There's a fourth part of internal carotid artery, also called the cerebral part of internal carotid. This internal carotid artery gives off a direct branch. A continuation of internal carotid artery is considered as middle cerebral. So this MCA, it is a continuation of the internal carotid, and this internal carotid also gives off this anterior cerebral artery as well. That's internal carotid giving off middle cerebral, and that is anterior cerebral. And I hope you can appreciate, and especially on this side, you can easily appreciate this artery here connecting the anterior, this one, internal carotid artery to the posterior cerebral artery, that is posterior communicating artery. Although it's very basic thing, but I've seen people getting confused with this posterior communicating artery. Posterior communicating artery, please remember, it is a branch of internal carotid. It joins with basilar. It joins with, with the posterior cerebral, not other way around. It's not the branch of posterior cerebral. It is a branch of internal carotid, and then it goes and then joins with the posterior cerebral artery. So that's how the circle of Willis is formed. We have anterior cerebral, which is connected somewhere by the anterior communicating artery. We have posterior cerebral here, posterior communicating, and we have internal carotid. Okay, we'll talk about this fossa in a while in the next section here. This is a picture just to show the major branches that you should be able to appreciate in this view here. So the vertebral artery forming the basilar, dividing into two terminal branches, and the two major nerves. That's important. The two important nerves, the third and fourth nerve, are seen emerging between the posterior cerebral and superior cerebellar artery. Well, beside the optic chiasma, guys, just lateral to optic chiasma, if you see the space here, this is called as a space, that space is called as anterior perforating substance. I'm just writing in short only, that is anterior perforating substance. Posterior perforating substance is inside the interpeduncular fossa, somewhere here. That is the posterior perforating substance, which again we'll discuss next. Now this, the one which is outside the interpeduncular fossa, is the anterior perforating substance, which medially is having optic chiasma, that is present on the medial side, the optic chiasma. Posteriorly is having the optic tract, and laterally, look at that sulcus kind of thing here, which is basically the beginning of the lateral sulcus. If you start from this point onward, that is the beginning of the lateral sulcus, and then lateral sulcus will emerge on the superior lateral surface and divides into the anterior division, ascending division, and the posterior division. That point, that region here, is called as limen insulae. That's a lateral relation of the anterior perforating substance. That's a question also asked in the AIMS exam. The lateral relation of anterior perforating substance is limen insulae, which is basically the point from where the lateral sulcus begins on the inferior aspect of the cerebrum and then emerges on the superior lateral. What exactly is anterior perforating substance? Anterior perforating, as the name suggests, is perforating substance. It is a gray matter area which is perforated by some arteries here. Well, what artery? It is perforated by what artery do you see closest? One is middle cerebral artery and anterior cerebral artery. So branches of anterior cerebral and branches of middle cerebral artery, they perforate this area and they go inside. Like one example I give you, let's say the anterior limb of the internal capsule is supplied by the artery called as artery. It's a artery called as a recurrent artery of Hübner or Hübner's artery. Just don't bother too much about it. So that Hübner's artery is a branch of anterior cerebral. How that anterior cerebral artery branch will reach the internal capsules to supply the anterior limb? By going through this perforating substance to supply some deep structures inside, the one which are in the core. So arteries have to go inside, and that's why they use this perforating agents here. So anterior perforating substance, it is perforated by the branches of MCA as well as branches of AC. That's about the blood vessel part. Now let me take you to this one important fossa which is present here, that is called as the interpeduncular fossa. It's a very commonly asked question about the interpeduncular fossa, its content. And there's another way the interpeduncular fossa is important, because if you know about the fossa, then you know a major chunk of third ventricle also. And you'll be like, what is about third ventricle here? Well, how can we see third ventricle from here? Well, third ventricle floor is somewhere here itself, guys. Whatever you see in the interpeduncular fossa, majority of the structures will be seen in the floor of third ventricle. So this question, this just the same picture here, but I'm using this fresh image here just to discuss this region here, that is the interpeduncular fossa. Well, first of all, why do we call it interpeduncular fossa? It is present between the two cerebral peduncles, the two peduncles of the midbrain, which cannot be seen clearly in this image because we have all these small blood vessels present. So that's the site where we have the two peduncles, and in between those two peduncles, this fossa here is called as interpeduncular fossa. If I may start with the boundaries here, the boundaries of interpeduncular fossa, as you can see, it is by the first thing is the optic chiasma. The first thing that you see here is optic chiasma. Then we have this optic tract. And the third thing is the cerebral peduncle, which is not to be seen, so I'm just marking it here somewhere. This is the region of the cerebral peduncle. That's the site of the cerebral peduncle. So these are three major boundaries of the interpeduncular fossa. The chiasma anteriorly, anterolaterally we have the optic chiasma, posteriorlaterally we have this cerebral peduncle. What are the contents? The contents of this fossa, interpeduncular fossa, if I may start from here, you can see this cut section of the infundibulum. Well, you know what is infundibulum, the stalk of pituitary, that's the infundibulum, that is the one content here. Emerging from this tubular elevation here called as the tuber cingarium. The tuber cingarium which is present, and on that you can see the stalk of the pituitary, that is infundibulum. I hope you can appreciate these two ball-like structures there. These are nothing but the mammillary bodies. One of the component of limbic system where the fornix fiber ends, this is called as the mammillary bodies. And just behind mammillary body, you see this is the posterior perforating substance. We just talked about the anterior perforating substance. Now this here is the posterior perforating substance. What is posterior perforating substance? Again, you can very easily make out by looking at what artery is nearby. We already saw basilar artery divided into the posterior cerebral artery. So it's the branches of posterior cerebral artery which goes inside to supply core of the midbrain part and all. Those arteries are called as the branches of the posterior cerebral forming posterior perforating substance. So guys, anterior perforating substance was the area which was perforated by the branches of anterior cerebral and middle cerebral, whereas posterior perforating substance is the gray matter area which is perforated by the branches of what? The PCA. That's posterior cerebral artery. That's the one which goes in. And finally, one more content that we have in this interpeduncular fossa here is this third cranial nerve. See, we already said fourth nerve is coming from dorsal aspect of brainstem. So you can see the fourth nerve here coming from the dorsal aspect. It's on the outer aspect of the peduncle here. This nerve, although it is coming out between this posterior cerebral and superior cerebral artery, but what you see, this nerve is actually a content of interpeduncular fossa. It comes out of the interpeduncular fossa and then it runs between these two arteries. So infundibulum, tuber cingarium, mammillary bodies, posterior perforating substance, and remember third nerve. These are the contents of interpeduncular fossa. So guys, this is about the ventral aspect of the brainstem here. Just a few more things to mark here. Like, you can see olfactory bulb over there. That's the olfactory bulb, and this is the olfactory tract. You can see the olfactory bulb. Just above this olfactory bulb, and tract, we can see this gyri recta or rectus gyri, the straight gyri that is called as a gyri recta. So this is the thing. At least these things you should be able to identify when you see this aspect of the brainstem. Okay, now it's time to turn the brainstem. Once you turn the brainstem and we remove the cerebellum, removal of cerebellum means exposing the floor of the fourth ventricle. That is our next section here, in which we'll be looking at the floor of fourth ventricle by turning the brainstem and removing the cerebellum from it. Okay, here's a picture showing the dorsal aspect of brainstem. See, it's not as simple as the way it looks like in the schematic line diagrams. You can see facial colliculus and sulcus limitans and locus ceruleus and whatnot in the floor of fourth ventricle. But when you see the real-time section, those elevations are not that clearly, differentiated. But we should be able to identify them because you never know where the pointer may be in the exam. Okay, one thing guys, when you turn the brainstem and once you remove the cerebellum, the fourth ventricle is seen, and fourth ventricle is present behind the pons, and some part is behind middle oblongata. But there is no part of fourth ventricle which is present behind the midbrain. So even if you remove the cerebellum, the one portion of the brainstem which will not be distorted or will not be disturbed at all is a midbrain. So right now, if you look at this portion here is a midbrain fourth part, and the dorsal part of the midbrain, as you all know, is called as a tectum. Tectum is made up of two colliculus. This here is the superior colliculus, and just below that is the inferior colliculus. So you're looking at the superior and the inferior colliculus. That's the superior and the inferior colliculus. If you look at this white matter bundle here coming from inferior colliculus, that is just basically called as the inferior brachium. This white matter bundle is called as inferior brachium, which will connect the inferior colliculus to the medial geniculate body. I hope you know that superior colliculus is related to the visual pathway, so it should be connected to the lateral geniculate body, and inferior colliculus is one of the component of the auditory pathway, so it need to get connected to the medial geniculate body. So it is getting connected to medial geniculate body by this white matter bundle, which I hope you can appreciate in this picture. That is called as the inferior brachium. For inferior colliculus, inferior brachium. For superior colliculus, it's superior brachium. Okay, here's the portion from where the cerebellum is removed, and that's how you can see the floor of the fourth ventricle. Now please understand this. The three part of brainstem, they are having the three peduncles: the superior cerebellar, the inferior cerebellar, and middle cerebellar peduncle. Peduncle is nothing; it's a white matter only. So white matter bundle which is connecting the brainstem to cerebellum is superior, middle, and inferior because we have three part of brainstem. But see, it's not like superior peduncle goes straight into the cerebellum or inferior goes straight into the cerebellum from the midbrain and pons or medulla respectively. The superior peduncle actually that goes downward. So what you'll see in this picture here, midbrain is here, but the peduncle of the midbrain, the superior cerebellar peduncle is here. And can you see the section over there, guys? This is the superior cerebellar peduncle. So clearly you can see this white matter bundle is coming slightly downwards. That's the superior cerebellar peduncle. Medulla oblongata is in this region. That's a medulla oblongata here. So you can see from the medulla peduncle that is coming up. Look at this section here. This is inferior cerebellar peduncle. And that peduncle that you see more on the outer aspect, that is a middle cerebellar peduncle, which is the peduncle of the pons. So all the major chunk of the fourth ventricle is present behind the pons, but in the boundary of the fourth ventricle, middle cerebellar peduncle is not playing a role. It's a superior cerebellar peduncle comes down, inferior peduncle goes with it, and middle stays more outside here. And that's why the boundary of the fourth ventricle is by superior cerebellar peduncle and inferior cerebellar peduncle, and it is also by these two tubercles here. Now I hope can you see this tubercle here? That is a tubercle of the medulla, and there's another tubercle here. Let me mark it for you guys. This tubercle, which is more laterally, this is more medially. The one which is present more medially here, this is called as a gracile tubercle. It's a gracile tubercle, and the one which is more laterally placed, this is called as a cuneate tubercle. With the name you can make out the gracile and the cuneate, the fasciculus gracilis and fasciculus cuneatus, the two dorsal column tract. Dorsal column tract is having one property that they keep on ascending on the same side of the spinal cord, unlike spinal thalamic tract which like this. So these dorsal column tract, they will reach the medulla oblongata, and in the medulla oblongata they have their nucleus called as nucleus gracilis and nucleus cuneatus. That's why this nucleus. That's why these tubercles there. So deep to these tubercles, we have those two nuclei present called as a nucleus gracilis and nucleus spiritus, where the dorsal column tracts are coming and relaying there, and from there the second order neuron for the dorsal column tract will begin. So this tubercle here, the gracile tubercle, is having a gracile nucleus or nucleus gracilis deep to it, and this cuneate tubercle is having nucleus cuneatus present deep to it here. They are also considered in the boundary of the fourth ventricle. So when it comes to the boundary of fourth ventricle, it's a superior cerebellar peduncle, inferior cerebellar peduncle, not the middle, and the two tubercle, that is a gracile tubercle and cuneate tubercle. Okay, now when we go, again before going inside the floor of the fourth ventricle, we already said that the only nerve coming from the dorsal aspect of brainstem is what nerve? Fourth nerve, the trochlear nerve. So look at this, below inferior collicus, can you see that very fine, the thinnest cranial nerve coming out in there? That nerve here is the trochlear nerve. The trochlear nerve, as you can see, it decusates within the midbrain only, and then it emerges out and will be coming out from the dorsal aspect of brainstem. And because it comes out of the dorsal aspect of brainstem, it has to wind around the brainstem and go forward. It not only is a thinnest cranial nerve, it is a nerve with the longest intracranial course also. Okay. In the floor of fourth ventricle, look at the sulcus present in the midline, guys. This sulcus here is called as a median sulcus. This sulcus is the midline sulcus here, and that sulcus is called as a median sulcus. Just lateral to median sulcus, this elevation, look at this where I'm pointing at right now, this entire elevation is called as a median eminence. First of all, guys, please remember this entire elevation is called as a median eminence. And on the median eminence, in this lower part of median eminence, this prominent elevation on the median eminence is called as the facial colliculus. That's a facial colliculus. So when you see a real-time section, it's not that easy to differentiate between the median eminence and facial colliculus. The way we draw it in the schematic diagram is very clear. We just show the median eminence and then we show something very circular which looks is a facial colliculus. No, nothing like that. It's not that simple. So this is the median eminence, guys, and this elevation on it, this here is the facial colliculus. This, to be more precise, that's the facial colliculus. See, there's a sulcus on the side, on the outside here, which is again cannot be seen very clearly in this section. The sulcus is called a sulcus limitans, and that is a sulcus which divides the neural tube into the two parts. Medial to sulcus limitans, we have majority of the motor nuclei placed. Facial colliculus is because of the facial nerve winding around what nucleus? It's the abducent nucleus. The nerve winding around is facial nerve. If there is injury to facial colliculus, first the facial nerve will be involved. That's a question also asked here. But if the question is asked, what is the nucleus present deep to the facial colliculus? That is obviously the abducent nucleus. It's a sixth nucleus. The facial nerve makes an internal genu around this abducent nucleus to come out, and that's why there's a prominence formed here. That is why the name is facial colliculus, which is actually representing the internal genu of the facial nerve. We come in the lower part here, guys, somewhere in this region. Now look at this elevation here, usually called as triangle, and see one which is more inferior laterally placed, this one here. The one above here, this is called as a hypoglossal triangle, and the one present below is called as a vagal triangle. Respective nuclei present here, the dorsal nucleus of vagus and hypoglossal nucleus are there. So the name is a vagal triangle, hypoglossal triangle. So this is a vagal triangle, the hypoglossal triangle. Look at the point where I'm pointing at, and more inferior laterally here, this is the vagal triangle, hypoglossal and vagal triangle. Lateral to sulcus limitans, this big area present on outer aspect here, this is the vestibular triangle here. Vestibular triangle. And anyways, we said that sulcus limitans is separating the motor and the sensory part of the neural tube. So medial to sulcus limitans, all these nuclei are present medial to sulcus limitans only. As I said, sulcus limitans is not to be seen very well in this, but all these nuclei medial to sulcus limitans. So be it hypoglossal, the vagal, or the facial colliculus, which is having abducent nucleus, all are motor nucleus. And lateral to this sulcus limitans, this big triangular region, is because it is having a vestibular nuclei placed deep to it. So we call it vestibular triangle, which is a sensory. I hope you can also appreciate some transversely running fibers, transversely running band over there. These fibers are actually coming from this median sulcus, then they run on the dorsal aspect, and then using the inferior peduncle, they go into the cerebellum, guys. These white matter, which is running transversely, is called as a stria medullaris. That is called as a stria medullaris. Stria medullaris. You are seeing the floor of fourth ventricle. These are the fibers which runs within the middle oblongata. They come from the dorsal aspect of the brainstem. Then they come out of the sulcus here. That is what sulcus? That is median sulcus. And then they will run laterally using the inferior peduncle. This whole thing is inferior cerebellar peduncle. That was a cut section only. So they use the inferior cerebellar peduncle to enter into the cerebellum. Stria medullaris. And look at this point here, this midline point here between this gracile tubercle, this inferior angle of this fourth ventricle here. This is called as the obex. O-B-E-X, that is obex. So these are the things that you should be able to identify when you're looking at the dorsal aspect of brainstem. Midbrain, no problem, it will look completely intact. The two colliculus can be seen. You can see the fourth nerve just below the inferior colliculus. You can see the fourth nerve coming out in the floor of fourth ventricle. In the boundary part, the superior and the inferior cerebellar peduncle. Middle stays outside, and the two tubercles, the gracile tubercle and cuneate tubercle, also forms the boundary part. Midline sulcus and median sulcus. You will see a median eminence also, and on the median eminence in the lower part, you will see the facial colliculus, which is formed by the facial nerve winding around the abducent nucleus. Hypoglossal and vagal triangle are also to be seen. Medial to sulcus limitans, and laterally we have this big triangle here. That is because of the vestibular triangle, also called as the vestibular area. That is about the dorsal and the ventral aspect of the brainstem. So next, guys, we'll start with the sections here. So as I said, we'll take three sections, the three basic sections that you should know. The transverse section, we'll consider transverse section slightly higher and lower from the middle part as well, and we'll take coronal and the styloid section also. So basically, we should be able to identify these structures in these sections because most of the time the questions are targeted on the structures which are pointed at. So our first goal is to identify the structure. Imagine the fornix is marked in the coronal section, and the question is asked on it. First, we should be able to identify whether it is fornix or something else. So that's the basic goal here is to identify the structures in these sections. Now guys, this is a transverse section in which you can see the right and the left half of the cerebrum. Now this half is slightly higher, the section is taken slightly above, and this is a bit lower section here. So I'm going to start with this section here, which is slightly higher, in which you cannot very clearly differentiate between the lentiform nucleus, cannot be seen in fact in this. So, and this is the section which is taken at the level of the lentiform nucleus. So if I want to start with this part here, with the right section here, I just wanted to focus at the 3-4 major features that you should be able to appreciate here. When you take a transverse section through the corpus callosum, the corpus callosum is shaped something like this, right? So when you take a sagittal section of corpus callosum, transverse section of the corpus callosum, then you will see the section will go something like this. It will go from the genu, which is the most anterior part, and the splenium being the most posterior part here. So this region here is some of the genu part of the corpus callosum in the transverse section, and this has to be the splenium part, which is even lower. But look at this white matter coming from the genu, and this white matter bundle running forward and connecting the frontal lobe. These fibers are called as the forceps minor fiber. Corpus callosum is the largest commissural fiber. Now, despite of being the largest commissural fiber, it cannot connect everything in the two cerebral hemisphere if the fibers were running only transversely and not moving forward or backward or downward. So they have to have some kind of adaptation in the fibers of corpus callosum. The fibers which are present in the anterior part, in the genu, they're not only running transversely, they have to go forward also to connect the frontal lobe. The fiber in the splenium, they have to go backward also, they have to go downward also to connect the temporal lobe, occipital lobe. So when you see the corpus callosum in a sagittal section, that is not giving you the overall idea about that how the fibers are spanning in the cerebrum. The transverse section is a better way to look at it. So this is the forceps minor fiber here, which is running forward. The fibers are coming from the genu of the corpus callosum and they are connecting the frontal lobe. I'm just paying attention to this side here. What else you can see in this section, guys? This is the head of caudate nucleus. That's a caudate nucleus, and this is actually the head of the caudate nucleus that you see here. And just behind that, another piece of gray matter that you see just behind that, it is actually again the caudate nucleus, but this is the body. Please understand, it's caudate nucleus. The nucleus is something like this. We all know that it's a comma shape, the caudate nucleus. If this is the caudate nucleus, if I take a transverse section somewhere here in the lower part, in this region, then I will see the head of the caudate nucleus, and that's it. But if I take a section slightly in the upper part here, so the section will go from the head of the caudate nucleus and also from the body of the caudate nucleus as well. So because the section is slightly above the upper part, so I can see the caudate, and along with that, I can see the head as well as the body of the caudate nucleus as well. When you see on the other side here, I can only see the head of the caudate nucleus. This is not the body. This is actually thalamus on the other side, on which the caudate nucleus is running. If there is a caudate nucleus, there is a thalamus here. You getting my point, guys? If this is caudate nucleus, there is a thalamus. If I take a section from above in this part, I'll see head and the body both. But if I take a section in this part here, I'll see head and the thalamus in the lower part. This is thalamus here. And this is not the section of thalamus, the rounded thalamus. You can see the upper surface of thalamus, which is more rounded here. Unlike here, where the thalamus is actually cut. There's a rounded surface, you can see it is the upper aspect of the thalamus. And if you can see very carefully, there's a vein which is present here. You can see it in the revision slide also. That vein here running on the thalamus is called as a thalamo-stride vein. There's a vein that you see running on it, that vein is called as a thalamo-stride vein. You can also appreciate the choroid plexus in this section. The choroid plexus can be seen. That's a site of the, we have a lateral ventricle in this region, which is having an anterior horn, which is having a posterior horn as well. So that's a choroid plexus which you can see. The choroid plexus of the lateral ventricle can be seen in there as well. So this is when you see this right half, which is the section taken slightly higher. The section which is of more use and the chances of again the questions to be asked more is on this side. So we have more things to appreciate on this side. So let me again take a fresh image for that to discuss that level. There we go. So same transverse section, just that we have just removed the higher one. We're just looking at the section from the middle part where the lentiform nucleus can be seen. So guys, see, this is again forceps minor. I don't have to mark it. This is the forceps minor fibers here. Here is the caudate nucleus, and this, you know that is what? That is a head of the caudate nucleus. That is a head of the caudate nucleus. If I just put a dotted line for you, this is the caudate nucleus here. This time, the section is slightly lower, so it's not the upper aspect of the thalamus. You look at the section is going through the thalamus. So that's the thalamus here. And lateral to it, this here is the lentiform nucleus. Look at this lens-shaped nucleus, the lentiform nucleus. This nucleus, just let me mark it here only. This is called as a lentiform nucleus. In other section, I'll tell you that what two parts we have here, putamen also and globus pallidus. So in this, we can just appreciate that's a lentiform nucleus. And let me try to enlarge it a bit more. I hope you can appreciate just lateral to lentiform nucleus. You can see a very, very thin sheet of gray matter over there. A very, very thin sheet of gray matter cannot be appreciated radiologically. That is called as a claustrum. That's a claustrum over there. And most laterally, this gray matter that you see most laterally here is an insular cortex. That is insula. I hope you all know about the insular hidden area of the brain called as the insula, also called as the island of Rheel. This is also called as the island of Rheel. The insular cortex, the insula, or the island of Rheel. Whatever marked till now here, all these are gray matter here. The head of caudate nucleus, thalamus, the lentiform nucleus, the claustrum, insula, that's all gray matter. Now look at the white matter in between. One white matter you already saw, that is a forceps minor here. Now this white matter which is running in this manner here, this is internal capsule. So guys, this here is the internal capsule, which also tells you about the relations of internal capsule. That's the anterior limb of the internal capsule between the head of caudate nucleus and lentiform. That's a genu part, and there is a posterior limb of lentiform nucleus, posterior limb of the internal capsule, which is between lentiform nucleus and thalamus. And behind the lentiform nucleus, we can see some part that is called as a retrolentiform part. There is a retrolentiform part of internal capsule. Let me take your attention to this portion only here. If I look at this portion, guys, what you'll appreciate here, you can see the posterior horn of the lateral ventricle. Lateral ventricle is quite a three-dimensional structure, isn't it? Lateral ventricle is like having this anterior horn, inferior horn, as well as a posterior horn. So if I took a transverse section in such a way that I can see this horn, that is a posterior horn of lateral ventricle. Here it is, that is a posterior horn of lateral ventricle. That is a posterior horn of the lateral ventricle. Medial to the posterior horn, you will see the fibers which are coming from the corpus callosum, the fibers which are coming from the corpus callosum. Even lateral to that, we again see a white matter which is also coming from corpus callosum. The one that you see coming from the genu, that was forceps minor. Now these fibers which are running backward here, medial to the posterior horn, these fibers are called as forceps major fiber. Look at this white matter bundle, it will be coming from the splenium of the corpus callosum. From the splenium of corpus callosum, the fiber will go backward to connect the occipital lobe and all. This is called as a forceps major, and forceps major, please mind it, it is present medial to the posterior horn. In fact, these forceps major fibers, that's such dominant fibers we have that they produce this elevation in the medial wall of the posterior horn, and that elevation is called as the bulb of posterior horn. This again could be a question here. The bulb of posterior horn is because of what? Bulb of posterior horn is because of the forceps major fibers. The bulb of posterior horn is because of forceps major fibers. When you see lateral to it, now look at this guys, lateral to this posterior horn, this is choroid plexus inside, just don't bother, that's a choroid plexus present inside. Now when you see lateral to the posterior horn, you can see a white matter here. In fact, it's a combination of two white matter. If you see the white matter which is just immediately lateral to this posterior horn, this here is called as the tapetum. Tapetum is a white matter bundle part of corpus callosum only, coming from the posterior part of body and the splenium, and they are seen running lateral to the posterior horn. Forceps major was present on the medial side of posterior horn. These fibers are also coming from splenium and the posterior part of body of corpus callosum, but they are running lateral to posterior horn. And guys, immediately lateral to the tapetum, another thalamus here. So behind the thalamus, you cannot see in this picture though, that behind the thalamus there will be the medial and lateral genital body, and from the lateral genital body, the radiations will come, and those radiations will go to the visual cortex. These are called as optic radiations, also called as posterior thalamic radiations. They run backward, and they're coming from metathalamus, that is the genital body, so we also call them posterior thalamic radiations. So this again are the structures that you should be able to identify in this section. Internal capsule, and the relations of internal capsule is quite clear here. The caudate nucleus, the head of the caudate nucleus, the thalamus, and the lentiform nucleus present laterally. Lateral to lentiform nucleus is the claustrum. Appreciate the white matter here, that is the internal capsule. And just to add one more thing to it, guys, this is called as internal capsule. See, the nomenclature of this internal capsule and external capsule is based on the basal ganglia. The one which is present inside this lentiform nucleus, inside the basal ganglia part, that white matter is called as internal capsule. The one which is immediately outside here, but inside the claustrum, I don't know if you can appreciate that in this picture, but you can see a very, very fine white matter which is outside the lentiform nucleus, but inside the claustrum, that is called as the external capsule. And the one which is even further out, which is outside the claustrum, is called as an extreme capsule. The external capsule is an extreme capsule. Then in the posterior part, we notice the posterior horn of the lateral ventricle. I always believe that this down the line could be a question, the posterior horn of lateral ventricle and its relations. The medial relation is the forceps major fiber, again coming from splenium. Immediate lateral relation is the tapetum fibers, and more lateral to tapetum, we have the optic radiations coming from the lateral genital body to the visual cortex. So again, this is something that you should be able to identify in the transverse section. I've recently come across some questions in which the transverse section is given, but that transverse section is given from slightly lower part here. So I want you to anticipate this thing, guys. When you take a transverse section even more in the lower part here, what you will see there and what you will miss. Let me put that section for you because that's the exact image which I got from some of the students, and I've used that image only here. Here's the one. Again, it's a transverse section, but there's some changes that you can see in there. But what changes I can see here, I cannot very clearly appreciate the anterior posterior limb of the internal capsule and all that. I cannot very clearly see the thalamus on here. So this section is quite low. It's obviously below the thalamus and all. What I see in this section here, once again, the head of the caudate nucleus is to be seen. This is the head of caudate nucleus. That's the head of the caudate nucleus. And look at this gray matter here. What, according to you, this gray matter could be? This gray matter, guys, is actually the cingulate gyrus. That is cingulate gyrus. Now let me just try to give you orientation around it. When you look at the corpus callosum, that's a genu and that's a rostrum of the corpus callosum. That's how it is. There is a gyrus which runs above it, that is called a cingulate gyrus, and turns in that manner, cingulate sulcus. And there's a gyrus called a cingulate gyrus present around the corpus callosum. You know, corpus callosum, despite of being the largest commissural fiber, it is not able to connect everything in the two cerebrum. So we need some small additional commissural fibers also. Below the rostrum of the corpus callosum, what you'll see another commissural fiber there, and that commissure is called as an anterior commissure. Please understand this point clearly. That's a corpus callosum, and below the rostrum of corpus callosum, there is a small commissural fiber, which I'll show you in the skeletal section, is called as an anterior commissure. And fornix is running something like this. Fornix is running in this manner, which again I will show you in the skeletal section. So I can see corpus callosum here. I can see this gyrus that is called as a cingulate gyrus, and below I can see the fornix, and below the rostrum of corpus callosum, there is this anterior commissure which is present. This is the mark it clearly. This is the anterior commissure. If I take a section like this, imagine if my transverse section is going that low. So what I will see here, if I take go section in this manner, that means first of all, in the anterior part, I will not see the corpus callosum. Corpus callosum rostrum is finished here, and I've taken a transverse section even below the rostrum of corpus callosum. But what three things you are able to appreciate here, and in the sequence, is what gyrus first, the cingulate gyrus. What behind that, what commissure, the anterior commissure, and what behind them is the columns of the fornix. You can see that's a fornix over there. Okay, let me take you to this part here, and let's see this thing here. Section going from this gray matter, this is actually cingulate gyrus. The cingulate gyrus. Then we have to see what? The anterior commissure, and behind that should be the columns of fornix. Behind the cingulate gyrus, look at this white matter bundle running transversely like this. This is the one which is pointed out in one of the exam also recently, and that's the main thing, guys. This is anterior commissure. This is anterior commissure, and what is the function of anterior commissure? It actually connects to some part of the temporal lobe. It actually connects the amygdala. It connects the amygdala. Remember that I've written in the revision slides also. The anterior commissure, which is present just below the rostrum of corpus callosum, the function is to connect some component of temporal lobe, and that is connecting the amygdala. Have a role in playing the memory and the sex drives also. And I hope you can appreciate in that. Can you see the two white dots over there? Look at that. Just behind the anterior commissure, if you look at these two dots here, what is this to be? These are the columns of the fornix. It's a column of the fornix. So this is something which I wanted to understand in this section, which is taken quite low. If you compare it to the previous one, the section is taken somewhere below the corpus callosum, imagine. So you're looking at this cingulate gyrus, the gray matter cingulate gyrus. Behind that we have, what is this? This is the anterior commissure, and then behind the two dots over that you see here is actually the columns of the fornix. The section is going in this manner, so it looks like the two dots, the columns of the fornix. In this section, what else we can appreciate here, is the lentiform nucleus. I can see the three part of the lentiform nucleus very clearly here. 1, 2, 3. You can see 1, 2, 3. The three part of the lentiform nucleus, if I just give them 1, 2, and 3 here. The most lateral part here, guys, that is number 1, that is putamen. 1 is for the putamen. 2 and 3. One slightly lightly stained and darkly stained, that is 2 and 3. Both are globus pallidus. That is a globus pallidus or globus pallidum. Number 2 is globus pallidus lateralis, call it pars lateralis. And that is globus pallidus pars medialis. So you can see this, the parts of the lentiform nucleus there. The outermost part obviously is the lentiform, this is the putamen, and then we have a globus pallidus, which again can be divided into two parts, the pars lateralis and the pars medialis. So that's one variation that you will see in this section. This section also shows the claustrum very clearly. Can you see the claustrum over there? And you can see the white matter inside the claustrum and outside the claustrum also, same external capsule and extreme capsule. So just look out for the transverse section, whether you're looking, are you able to see the caudate nucleus, and along with the thalamus can be seen? Can you see the posterior horn of the lateral ventricle in it or not? So like these small things, that small hint that will work, and you need to identify. This is one of the things in this section which I always believe is important, and they ask this question also as an image-based question, that is anterior commissure connecting the amygdala. So guys, this is about the transverse section. I hope you should be able to identify at least all the major structures in these transverse sections. Now from the transverse section, let's now move on to the coronal section, and in that coronal section we'll also be covering the lateral ventricle. So guys, here you're looking at a very nice high definition image of the coronal section of the cerebrum, and this section is actually going from the body of the lateral ventricle. So it's not the anterior posterior horn. This time you're looking at the body part. That's the lateral ventricle, and the section is going from body. Well, let's first mark the things that we already saw in the transverse section. That's another view of that. This here again, that is the internal capsule. Look at this white matter here. That is the internal capsule. Let me mark all these things on one side here. That is internal capsule. And once you see this internal capsule reaching the level of the corpus callosum, can you see the white matter clearly? And once it reaches the level of the corpus callosum, it radiates in the cerebrum, and that's how we call it what? Corona radiata. The internal capsule, once it reaches the level of the corpus callosum, then you see it radiating and going to the respective part of the cerebrum that is called as corona radiata. Before I go to this portion here, the important part, I wanted to focus on this lower part. The three part of brainstem can be seen here. That is the midbrain here, there is pons, and there is medulla oblongata. A few hints in there. Look at it. If this is a midbrain part, first of all in the midbrain, look at this a stained region here. That is substantia nigra. So substantia nigra can be seen there. This portion is a portion of pons. In direct contact with direct relation to the cerebrum, there is a pons here. And below here, this is medulla oblongata. And you can also appreciate the two important elevations of medulla oblongata, although you cannot see what is deep to them very clearly here. Look at this. Can you see this one elevation here and one elevation in the front here? This elevation is because of inferior olivary nucleus, and we call it olive. And this elevation here, the ventral part, that is called as pyramid. That you know that is because of the pyramidal tract or corticospinal tract. So in the medulla oblongata, in this section, I can see this. That is a olive here, and that more ventrally placed. This is a pyramid. This whole thing is a pyramid. You can see the longitudinal view of the pyramid as well. Okay. Now going to the upper part, here is the lateral ventricle. This here is the lateral ventricle. And the one here is the third ventricle. There's a third ventricle. We already will see the third ventricle in the next section, but this section will help you to understand the next one also. Once again, guys, before we go to the boundary of this lateral ventricle or the third ventricle, now if this is the internal capsule, can you see this gray matter lateral to internal capsule here? This once again is what? That is a lentiform nucleus. And lateral to lentiform nucleus, look at this gray matter here. This was the section asked in the AIIMS exam in which they gave a coronal section, and insula was asked. So this here is the insula. In the coronal section, the insula, the hidden cortex. Unless you open this lateral sulcus, you're not able to see this area. That's why we call it a hidden gyrus here. The insular gyrus or insular cortex here. You have to go through this lateral sulcus, open it up, the sylvian sulcus, and then you can actually reach and see all those, all that area that is called as the insula. So lateral to internal capsule is what? Lentiform nucleus. What about medial? Medially, again, we have what? That is a caudate nucleus. And this time it's a body of caudate nucleus. It's a coronal section, guys. And it's a coronal section not from the anterior body. If this is the caudate nucleus, the section is not very much from the anterior part, it is from the body of the lateral ventricle. So this time you'll be looking at the body of the caudate nucleus only, not the head. So that's a caudate nucleus, and below we have the thalamus. That's a caudate nucleus thalamus. That's the only thing is this time you're looking at in the coronal section. Talking about the boundaries of the lateral ventricle, what do you see? This is a median fissure, right? That's a median fissure. And here clearly is the corpus callosum. That's the corpus callosum, which is the connecting the two cerebral hemispheres, the largest commissural fiber. And corpus callosum is one major structure forming the roof of the lateral ventricle, as you can see. So corpus callosum is forming the roof. Medial wall is by this a very thin septum here, and this septum is called as septum pellucidum. Again, just labeling it randomly here. It's all clearly labeled in the revision slides. That is septum pellucidum, and that's a major medial wall here, the septum pellucidum. And then majority of the structures here are forming the floor of the lateral ventricle. So we don't consider lateral wall. We simply say we have a roof, we have a medial wall, and we have this floor of the lateral ventricle. And as you can see, the floor of lateral ventricle is by the caudate nucleus, the head of the caudate nucleus. There is a head, right? Then it is by a vein in between. Can you see a vein between the thalamus and the caudate nucleus called as a thalamostriate vein? I showed you this thalamostriate vein in the transverse section also. A higher transverse section which you saw the thalamus, and there was a vein running on it. That is the thalamostriate vein between the thalamus and the corpus striatum. So the name is thalamostriate vein. This, of course, is the thalamus, and this here is the fornix. That is the fornix, the body of the fornix can be seen. Previously we saw the columns of the fornix, which is the anterior part. That's the body of the fornix. Another previous AIIMS question from here in which they gave a coronal section also only, and in that coronal section they put an arrow on the fornix, and the question was that following fiber originates where? We should first know what is the following fiber. So the first job is to identify what the arrow is on. So arrow was on the fornix here, and that fornix, and see there are two fornix here which come very very close to each other, looks like a single unit only, and they go downward and they end in the mammillary bodies. So if the question says where the fornix fiber originate from, they originate from hippocampus. Where they end in mammillary body. Originates in hippocampus, ends in mammillary body. Fibers are going forward like this, and they ends in mammillary bodies. And you can also see a plexus over there if you could appreciate in this picture. Can you see the plexus? That is a choroid plexus here. The choroid plexus of the lateral ventricle and the choroid plexus of the third ventricle here. So that's a choroid plexus. If I get a space to mark it here, this is the choroid plexus. So all this is the floor here. The caudate nucleus, thalamus, right vein, choroid plexus, they are all forming the floor of this lateral ventricle. Medial wall is by the septum pellucidum, and the roof is by the corpus callosum. So previously in the dorsal aspect of the medulla oblongata of the brainstem, we saw the fourth ventricle boundaries, and fortunately in the coronal section we can cover up the boundaries of the lateral ventricle here. So whether it's a theoretical question or it's an image based, you should be able to identify these structures in this section. Okay, one more section that we'll take here. We're done with the coronal, we're done with the transverse, and now finally we'll take a sagittal section to wrap up this session. In this sagittal section, guys, we will be looking at the corpus callosum part, we'll be looking at the other commissural fibers also, and most importantly, we'll be looking at the boundaries of the third ventricle also. Okay, here is the sagittal section that we'll be considering. Now, before I discuss the structures which are forming the boundary of this third ventricle and about the aqueduct of sylvius and lateral ventricle also to be seen here, guys, this here is the corpus callosum, right? And if this is corpus callosum, going with the parts of corpus callosum, we have this body of the corpus callosum. This is the genu part, anteriorly placed. There is a splenium here, and below we have the rostrum here. So that's a rostrum here. I'm just telling you there is a rostrum here. In this section, a septum is removed from below the corpus callosum. The septum that we saw below the corpus callosum was septum pellucidum. This is septum pellucidum. I'm just using a different image here to show that how the septum pellucidum look like. That's a corpus callosum. That's a fornix here, right? There's a fornix. Look at that. That's a corpus callosum. This is the fornix. And look at this translucent septum. septum between, there is a septum pellucidum, which is forming the medial boundary of both the lateral ventricles. So the section that we're looking at, in which the septum pellucidum is not seen, but the other structures can very clearly be appreciated. So let me go back to that. It is just to show you the correlation in between. Coming back here, the sulcus, that was the sulcus I was talking about. This was a cingulate sulcus here, and the gyrus is called a cingulate gyrus. This gyrus here is a cingulate gyrus. If this is a cingulate gyrus, coming back to the same point, if this is a cingulate gyrus, that's a rostrum of corpus callosum. Here is the anterior commissure. Can you see the commissure over there? If I can show it to you just enlarged. Look at this, the cut section of this anterior commissure, and just behind the anterior commissure, you can see the column of the fornix. Look at that, that's a column of the fornix. Let me mark both for you. This here is the column of fornix. That commissure is the anterior commissure. And just below the anterior commissure is this here is called as the lamina terminalis. That is lamina terminalis. That is lamina terminalis. Well, all these three structures, the column of the fornix, anterior commissure and lamina terminalis, they are forming the boundary of the third ventricle. Where is third ventricle here? That's the third ventricle. This picture is showing the third ventricle, and the anterior wall of third ventricle, look at this, it is by the three things here, the column of the fornix, it is by this anterior commissure and by the lamina terminalis. I think we should not bother about the roof that you already know. In the coronal section we saw that below the septum pellucidum we have the fornix, and below the fornix was the choroid plexus. That means this fornix will be there here, the body of the fornix will be somewhere here, this will be the body part of the fornix here, and then we have a choroid plexus also. So body of the fornix and choroid plexus will be in the roof. Posterior wall, what is there in the posterior wall? Below the splenium of corpus callosum, you can very clearly appreciate this gland here, that is a pineal gland. That's a pineal gland. And if you look carefully guys, just below the pineal gland there is a commissural fiber present below, and that commissure is called as a posterior commissure. The commissure which helps to connect the superior colliculus and accessory oculomotor nucleus, that is called as a posterior commissure. It is below the pineal gland, or you can say it is present in the inferior lamina of the pineal gland. Pineal gland is having an inferior lamina and the superior lamina. Superior lamina is not very clearly seen here, but superior lamina will be here, and that superior lamina will be having a commissural fiber that is called as a habenular commissure. It's a habenular commissure present in the superior lamina of the pineal gland. And just below posterior commissure guys, if we already said if this is the third ventricle, this we already know it is a fourth ventricle which is present behind the pons, right? That's a pons here, this is medulla oblongata, that is cerebellum, this is midbrain. So if this is the fourth ventricle, then obviously this is the aqueduct of Sylvis. So that's the fourth thing, the aqueduct of Sylvis. That's the aqueduct of Sylvis, which is also forming the posterior wall. So anterior wall of the third ventricle is by what? It is by the column of the fornix, it is by anterior commissure, and it is by the lamina terminalis. Posterior wall in a sequence, looking at the present scenario, you should also know the sequence of the structures as well. Posterior wall is by what? Habenular commissure, the pineal gland, we got this posterior commissure, and then we have this what? That is the aqueduct of Sylvis. Roof we already said that is by the body, and that is by the choroid plexus. Okay, floor, coming to the most important, there is a floor here guys. Let me take you back to interpeduncular fossa. The first image that we discussed was of the interpeduncular fossa. I told you if you know the floor of the interpeduncular fossa, the content in that, then you know the floor of third ventricle also. If you remember all the structures present in the midline, in the interpeduncular fossa, it was what? Optic chiasma was there. Just behind optic chiasma there was an infundibulum coming out of tuberous cyanidum. Just behind that what? There was mammillary bodies, and we also have posterior perforating substance. If you just go back and think about the interpeduncular fossa, whatever I just said, they are the structures present in the interpeduncular fossa. The optic chiasma is the boundary. Behind that we have the infundibulum and tuberous cyanidum, the mammillary bodies, and the posterior perforating substance. Third nerve is also there in the interpeduncular fossa, but let's ignore the third nerve because that is going actually more outside. Okay, keeping those structures in the sequence in mind, now look at this picture. Let me just rub this off. Anyways, it's there in the review slide. And I wanted to focus on the floor here guys. The floor in the sequence, if you see this picture from this side, from this aspect, from the inferior aspect, then it is interpeduncular fossa. But when you see these structures from this aspect here, that is forming the floor of third ventricle, and the sequence of the structure is the same. It's the optic chiasma, there we have it. Just behind that is infundibulum. I'm just writing I for the infundibulum. You can see that is the infundibulum. This is very clearly appreciated. There is a mammillary bodies. Behind mammillary body, that is the posterior perforating substance. That is a posterior perforating substance, remember, which was perforated by the branches of PCA. And then you can see some part of midbrain. See, the dorsal aspect of midbrain, which is present behind the aqueduct, was tectum. This part of midbrain is called as a tegumentum. So tegumentum of the midbrain can also be seen here. All these are forming the floor of the third. So guys, I very strongly believe that the most important section is the sagittal section only. Even if this current aims also, there was a question asked on the fornix in the sagittal section only. So this I believe is a very, very important section. The third ventricle, its boundaries, the fornix, the part of corpus callosum can be seen. We can see the fourth ventricle. There is a posterior recess of the fourth ventricle extending backward. This triangular recess is called as posterior recess of fourth ventricle. So there is a lot to be appreciated in this section. So if I may very, very quickly repeat the section for you. So this is the third ventricle here. Third ventricle, there is a lateral ventricle above, there is fourth ventricle below, there is third here. Anterior wall of third ventricle, three things. What three things guys? That is what we have a column of the fornix, we got anterior commissure, and then we got lamina terminalis. Posterior wall in a sequence, habenular commissure, pineal gland, posterior commissure, and then aqueduct of Sylvis. Roof, we saw it in the previous section only. That is formed by what of the fornix, the two fornix coming in there, and then we have a choroid plexus present below it. Floor, by the optic chiasma, infundibulum, mammillary body, posterior perforating substance, and tegmentum. Whatever you saw in the interpeduncular fossa, barring third nerve. There is no third nerve in the floor of the third ventricle. So that is there in the floor here. Whereas lateral wall, if I see, just let me rub this off here. If I again just kind of highlight it for, enlarge it for you, this elevation guys here is actually thalamus, and this here below is the hypothalamus. There is thalamus here, and this is hypothalamus, and you can see a sulcus also in between. This sulcus is called as a hypothalamic sulcus, which is guiding the CSF from interventricular foramen to the aqueduct of Sylvis. From the interventricular foramen to the aqueduct of Sylvis, that is the hypothalamic sulcus. They are present in the lateral wall of the third ventricle. The thalamus, the hypothalamic sulcus, which is basically guiding the CSF from the interventricular foramen, which is here, to the aqueduct of Sylvis. So they are forming what wall? The lateral wall of the third ventricle. So this is about the some important sections of the brain that before going to the exam that you should know. I mean, the questions could be anything, guys. Question could be about the blood supply. Question could be about the whether it forms the boundary of the certain ventricle or not, or anything. But our first goal is to identify those structures. Even for the radiological images, if you can identify the normal anatomical sections, then only you can identify them on the radiograph as well. So that's all for this session, and in the next section we'll meet and we'll talk about the other the small topics of the remaining part of the anatomy. Thank you. So guys, the next topic we are starting with is the cerebrum, and in the cerebrum first let us start with the types of the sulci and gyri. We'll see what type of sulcus we have, how we classify them. Then we will go on to the cortex, the cerebral cortex, where we will talk about the homunculus, the different areas of the cerebrum. We'll also talk about the cerebral histology also, and then followed by the most important topic I would say in the entire neuroanatomy, that is the white matter of the cerebrum. So let us first start with in the cerebrum, let's start with the types of the sulci. So we're starting with the types of sulci. Now, as you know, there are so many sulcus we have in the brain, all those sulcus like the central sulcus and calcarine sulcus. So how we classify those sulcus? So we broadly classify these sulcus into the following categories. Like there is one type which is called as a limiting sulcus. That is called as a limiting sulcus. Now, what's a limiting sulcus? As the name suggests, the sulcus which is limiting the two different areas, but the important thing is that limitation is at the floor of the sulcus, or very much in the depth of the sulcus. Let me explain that diagrammatically. Let us say this is one gyrus here, and there's another gyrus here which with a different function. So as you can see, this, if you look at the depth of the sulcus, there is a point where these two areas are meeting. Now let's say there is a sensory area and motor area. So they must be meeting at some point. That meeting point over there is found in the depth of the sulcus, and those type of sulcus are called as what? Limiting sulcus. So the sulcus, these are the sulcus which separates different areas at the floor of the sulcus. The floor is a keyword here. They're separating, but at the floor of the sulcus. The example of the limiting sulcus will be, the best example will be the central sulcus. And another example is the calcarine sulcus. I'll tell you more about this sulcus when we'll look these sulcus on the areas of the brain. So the central sulcus, especially the sulcus, central sulcus, we all know, separating the sensory and the motor cortex. And this separation of the sensory and motor cortex is very much at the depth of the sulcus here. Please also remember that central sulcus is also called as a Rolandic sulcus. It is also called as a Rolandic sulcus. The second in the category is called as the operculated sulcus. That is the operculated sulcus. What are operculated sulcus? Now once again, let me use the diagram to explain that. Now let us say this is some area with whatever function, and look at this different color here, which is representing the area with a separate function. So now you're looking at the two different type of areas again, but this time the zone of transition or the meeting point is not in the depth, it is very much at the margin, or you can say at the operculum. Operculum means what? Lips. So when you open this lip here, when you open the sulcus, you will see that there is an entirely different area which is present inside. So basically, operculated sulcus are just like limiting sulcus only, but the difference is their transition is not in the floor, the transition is at the top, is at the lip. So I would say they are just like limiting sulcus, but transition is at lip. The transition there was at the floor, that was the key thing here, and this here the transition is taking place at the lip. That's the area from where the function will change. The example for the operculated sulcus will be the lunate sulcus. As I said, we'll discuss all these sulcus in a while. That is the lunate sulcus. Lunate sulcus is the one which separates. Lunate sulcus separates striate and peristriate area. It separates striate and peristriate area. That is the second type of sulcus, that is operculated sulcus. Now quickly moving on to the third type. The third type of sulcus is called as the axial sulcus. That is called as axial sulcus. Now what is axial sulcus, guys? Axial sulcus are those sulcus which separates the different areas, but that is based on how they are winding around the sulcus. What I'm trying to say here is, let us say if there is one sulcus, and around that sulcus if you see the different type of areas are developing and they are using this sulcus as an axis. The best example like visual cortex. If you look at the visual cortex, we have a calcarine sulcus, and around the calcarine sulcus we got area number 17, then we got area number 18, and then we have area number 19 which is further around it. So that type of sulcus is called as what? Axial sulcus. The word axis is important here. So this is the gyrus here, that is the sulcus against the gyrus. So look at this is what I'm talking about. So you can see all these different type of areas developing around the sulcus. So basically sulcus around which different areas develops. Around which the different areas develops. And the example for the axial sulcus is the posterior part of calcarine sulcus. The posterior part of calcarine sulcus is an example here. So calcarine sulcus, yes, but which what part of the calcarine sulcus? The posterior part. And then lastly we have the fourth type, and that is called as the complete sulcus. That is the complete sulcus. Now what is the complete sulcus, guys? Again, let me try to explain that with the diagram here. If this is a sulcus, the sulcus which is going so deep inside that it is indenting the wall of the ventricles. So here's the wall of the ventricle, let's say it's a ventricle here, obviously the lateral ventricle, maybe any horn of lateral ventricle. So if the sulcus goes deep inside, and it goes so much deep inside that it ends up by putting an impression or making an impression on the wall of ventricle, that is called as a complete sulcus. So these are sulcus which are deep enough to indent the walls of ventricle. They're deep enough to indent the walls of the ventricle. The example for this type would be, one is the anterior part of calcarine sulcus, one calcarine sulcus. We just saw posterior part of calcarine sulcus was the axial. So here we have an example of anterior part of calcarine sulcus. And another example is the collateral sulcus. Anterior part of calcarine sulcus and the collateral sulcus. Let me just use a different color for the collateral sulcus. Now, I mean, if I have to show you that what exactly they are indenting, we are still supposed to discuss this ventricle in a while. But look at this. If this is a lateral ventricle, let's say, and we know that lateral ventricle is having this anterior horn, we got inferior horn, and this is the posterior horn. So this calcarine sulcus, if I go with the color code, anterior part of calcarine sulcus will indent the posterior horn, and the collateral sulcus will indent the inferior horn of the lateral ventricle. And those elevations which are formed here because of these respective sulcus, go with the color here. Anterior part of calcarine sulcus forms an elevation on the posterior horn, and that elevation is called as calcar avis. That is a calcar avis. Whereas the elevation which is formed on the inferior horn of the posterior of this lateral ventricle, which is because of collateral sulcus, is called as collateral eminence. That is collateral eminence. Now, where exactly this collateral eminence and calcar avis are, we will discuss that. But just to again remind you that that is why we call them the complete sulcus, because the calcarine sulcus, the anterior part of calcarine sulcus is indenting the posterior horn, and the collateral sulcus is indenting the inferior horn of the lateral ventricle, called as the collateral eminence and the calcar avis. So one important thing to note from here is that the sulcus which is counted in all three, which is limiting also, which is axial as well, and now you can see this complete sulcus as well, is a calcarine sulcus. So that again can be a question asked, that which sulcus is counted in all three categories. And the question remains is that if we just cover like 4 or 5 examples in this in the classification of the sulcus, what about the other sulcus that we got? There's so many sulcus we have in the cerebral hemisphere. For the majority of the sulcus or the remaining sulcus in the brain, they don't fit into any of the category, and we call them incomplete sulcus. So the other examples apart from what we discuss here, most of them will come into a category which is a kind of 5th category you can say, and that is called as what? Incomplete sulcus. The sulcus are called as incomplete. So that is about the classification of the sulci. So guys, having talked about the types of sulci, now let's talk about the important areas in the brain. So first we'll begin with the superior lateral surface of the brain. We'll see what are the important gyrus and sulcus we have and the important areas, and then we will look at the medial surface of the brain, and we'll also look at the areas in that region. So I'm going to start with the superior lateral surface of the brain. So when you see the superior lateral surface of the brain, this is how it's going to look like. This is the Sylvian sulcus, and let's say this is the central sulcus, right? The two sulcus which we can easily identify, the Sylvian sulcus and the lateral sulcus. Sylvian sulcus and lateral sulcus. Now this Sylvian sulcus is actually only the posterior limb of lateral sulcus. When the lateral sulcus emerges on the superior lateral surface of the brain, it is having 3 extensions. One is the upward extension like this, and then we have anterior extension also. And the one that you're looking at going backward, it is the longest posterior extension of the lateral sulcus. This here is pre-central gyrus. This is post-central gyrus. I'm sure you all know that pre and post-central gyrus. Let me mark this, only this one, the central sulcus. This is called as central sulcus, also called as Rolandic sulcus. Central or Rolandic sulcus. Now what you see, all these 3 limbs of the lateral sulcus, they are all present in the inferior frontal gyrus. So these are 3 frontal gyrus we're looking at, the superior, middle and inferior frontal gyrus. Just make sure all these limbs are extending into the inferior frontal gyrus. We got 3 gyrus in the temporal lobe also. This is superior temporal, middle temporal and inferior temporal gyrus. On the top of these sulcus we have a supramarginal and angular gyrus as well. We'll see all these areas. I'm just drawing it first. And please also draw a line here dividing the parietal lobe. This is parietal lobe. It is dividing the parietal lobe into superior parietal lobule and inferior parietal lobule. And this here is a calcarine sulcus. This here is a calcarine sulcus. So I'm going to draw it twice actually. Let me just mark the important areas here first, and then we will see what is present where. Now this here is the pre-central gyrus. This is a pre-central gyrus, and this is a post-central gyrus. This is superior frontal gyrus. We got a middle frontal gyrus, and this is inferior frontal gyrus. I'm just writing them in short. So this is superior frontal, middle frontal, inferior frontal gyrus. What you see that in the inferior frontal gyrus, please notice these 3 areas here. This one here, which is between the posterior limb and ascending limb of the lateral sulcus. Then we have the one between the ascending limb and the anterior limb. And the one that you see which is present inferiorly toward the orbital surface of the cerebrum. And that is how they are named. If I give it A, B and C. Guys, A here, that's an important area called as pars opercularis. This is called as pars opercularis. Whereas if you look at this B, which is between the ascending limb and anterior limb, this is called as pars triangularis. This region is called as pars triangularis. And if you look at the area C which is present below this anterior limb, that is called as pars orbitalis. That is pars orbitalis. So we have these 3 important areas here: pars opercularis, triangularis and orbitalis. Especially these 2 are very important because they will have Broca's area in them. So we'll talk about them in a minute. Then please also mark this important area which is present here. That is a superior temporal gyrus, middle temporal gyrus, and then we have inferior temporal gyrus. The 3 temporal gyrus: superior, middle and inferior temporal gyrus. Then we said we have parietal lobe divided into this superior parietal lobule, and this is inferior parietal lobule. Larger gyrus is called as lobule. So we simply call them lobules. It's a gyrus only. So we have a superior parietal lobule and inferior parietal lobule. This is interparietal sulcus we are looking at. And this obviously, this sulcus is the calcarine sulcus. That's an important one. The calcarine sulcus, which we just discussed. Calcarine sulcus, which is a type of a complete sulcus, a limiting sulcus, an axial sulcus, that calcarine sulcus. Please also mark these 2 important areas here. That is this one and this one. Let me again give them some numbers or something to remember. So let me give them D and E. The D, area D, that is called as supra marginal gyrus. This is called as supramarginal gyrus. That is D, supramarginal gyrus. And E here is for the angular gyrus. Another important area, that is supramarginal and angular gyrus, you will find components of Wernicke's area are present here. So this is just the superior lateral surface we're looking at, and the important gyri and sulci. Now let's use the knowledge of all these, where these gyri and sulci are, and let's mark where the important areas are present, what their function is, and any injury to those areas will lead to what. So I'm again going to take the same diagram here, guys, but this time we'll be marking areas on it. So there we go, once again, the superior lateral surface. The central sulcus, pre-central, post-central gyrus. Now please note that the post-central gyrus is the sensory area, that is area number 3, 1 and 2. Whereas the pre-central gyrus, that is area number 4. If I may draw these extensions of the lateral sulcus, which are present in the inferior frontal gyrus, that is superior and inferior parietal lobule, and once again the temporal lobe, and behind that we have the supramarginal and angular gyrus. So this time we'll be writing the numbers of these areas. This classification obviously is called as Brodmann's classification, and look at this area number 4, which is in front of the central sulcus. Now in front of this area number 4, occupying the part of superior frontal, middle frontal, and some part of inferior frontal gyrus also, look at this area which I'm highlighting here. It is present in all the 3 frontal gyrus, the most posterior part of all the 3 frontal gyrus. This is area number 6. We call it pre-central gyrus. I'll write about that also in a minute. That is area number 6. Then in front of the 6, especially in the middle frontal gyrus, that is area number 8. Let me highlight that also. That is area number 8. Superior parietal lobule is area number 5 and 7. You can see it's a parietal lobe. We said it is parietal lobe is divided by the sulcus. The sulcus is interparietal sulcus, and we have a superior parietal lobule having 5 and 7. Coming to this very, very important area here in the inferior frontal gyrus, that is area number 44 behind and 45 in front. 44 behind and 45 in front. This is 44, and then in front we got this 45. Remember this area, the pars opercularis and pars triangularis. It's very, very important area, 44 and 45. Then in the superior temporal gyrus, we will have auditory cortex, and auditory cortex is area number 41 and 42. Just write these numbers with me. I'll be writing all these areas for you separately as well. That is 41 and 42 in the superior temporal gyrus, the auditory cortex. Surrounding this 41 and 42 is area number 22, which also is a component of Wernicke's area, area number 22. And then guys, this is area number 39 and 40. As you can see, you already know the name here. 39 is in the angular gyrus and 40 is in the supramarginal gyrus. 39 and 40. So some important areas. There are so many areas in the Brodmann's classification, you don't have to remember everything. So at least remember the important areas, and these are the ones which you can appreciate on the superior lateral surface. So let's do one thing. Let us write down these areas separately one by one and see what exactly their function is and what the injury may lead to. So there we go. Let us start with these very basic areas that we started with. That is area number 3, 1 and 2. And guys, see, I will be writing the whole thing again because like 3-4 years back, nobody used to ask many questions from these areas of the brain. But since all these image-based questions are in trend now, so nowadays they will just give you the picture of the cerebrum and just they'll put the arrow wherever they want, and they might ask you that what is the area, what is the blood supply of that area, injury to that area will lead to what are the effects of the involvement of that areas. So it's very important to know the number of the area, important areas at least, what is their function, and their blood supply also, which we will discuss eventually. So 3, 1 and 2. What is the location of 3, 1 and 2? This is present in the post-central gyrus. It is present in the post-central gyrus, isn't it? And this area number 3, 1 and 2 present in post-central gyrus. The function is this is actually the primary sensory area or primary sensory cortex. This is the primary sensory area or the primary sensory cortex. Primary sensory area or primary sensory cortex. Any injury to this area, let us say this sign, let's say it's for the injury here, any injury to this area will lead to the contralateral sensory loss. Contralateral, isn't it? Most of the tracts were decusating to the opposite side to reach the thalamus, and then thalamus will give the thalamic radiations reaching this region here. So let's say the injury is on the, let's say one example, if the injury is on the right cerebral hemisphere, so there will be loss of the touch and pressure sensation of the left side because the tracts were decusating in the brainstem or in the spinal cord to ultimately reach the cerebrum. Then we have this area number 5 and 7. I want you guys to think about it. Where is area number 5 and 7? Where you draw it? You draw it in the superior parietal lobule. You draw it in the superior parietal lobule. What this area is, this area number 5 and 7, which is the superior parietal lobule, this is also called as sensory association area. This is also referred as sensory association area. For most of the areas we have there association areas also. This is sensory association area. The association areas are for the previous experiences and past memory. That's what the association area will do. I mean, I can see an object coming towards me from a visual area. But what exactly that object is, what it can do to me, anything about that, the knowledge about that object is stored in my previous experiences, or you can say in my association areas. So association, whenever you say visual association, auditory association, or simply sensory association, so they are related to the previous experiences and past memory, which will help you recognize that particular thing based on whatever sensory stimulus you are using that time, visual or auditory or maybe by touching it. So if there is any injury to this sensory association area, if there is any injury to the sensory association area, that will lead to the tactile agnosia. That will lead to the tactile agnosia. The inability to perceive the roughness or the texture of an object, that will be there. So tactile agnosia will be there in case of the injury to this area number 5 and 7. Then coming in front of the central gyrus, then we have this area number 4. Very, very important. Area number 4 again. What is the location for area number 4, guys? That is present in the pre-central gyrus. Area number 4 is in the pre-central gyrus, and this is the primary motor area or primary motor cortex. This is the primary motor area or the primary motor cortex. And please note this primary motor cortex is the one from where we have, it is a main site for the origin of the corticospinal tract. Pyramidal tract or corticospinal tract. So it is a site for the origin of, let me write, pyramidal tract. Obviously, any injury to this area, primary motor area, will lead to the contralateral hemiplegia. It will lead to the contralateral hemiplegia. Then we have area number 6, which is right in front of the 4. Now, if you look at what is the location of the 6, area number 6 is located in the superior frontal gyrus, middle frontal gyrus, as well as inferior frontal gyrus as well. So it is situated in all the 3 frontal gyrus, superior, middle, and inferior, the posterior part of the 3. The posterior part of the 3. This area number 6, please note, it is the premotor area. This area is called as premotor area. It is in front of the motor area. It is in front of the 4. So we call it premotor area. And this premotor area, it is a site for the origin of extrapyramidal tract. It is a site for the origin of extrapyramidal tract. That is a site for the origin of extrapyramidal tract. All those corticorubral and corticobulbar and corticopontine, apart from the pyramidal tract, whatever descending tracts we have coming from the cortex, that is extrapyramidal tract, they will originate from this area number 6. Okay. And if there is injury to this area number 6, there will be the case of apraxia. Injury to area number 6 will be the case of apraxia. There will be difficulty in performing the skilled movement. So apraxia, difficulty in performing the skilled movement, will be the cause if there is area number 6 is affected. Moving on, guys, in front of the 6 we saw area number 8. Area number 8, which is situated in the middle frontal gyrus. Well, it is not only in the middle frontal gyrus. Many books will show you that this area is projecting into the superior frontal gyrus also, and you can see it on the medial surface of the cerebral hemisphere along with area number 9. But you should mainly it is in the middle frontal gyrus, the area number 8. This area is called as the frontal eye field area. That area number 8 is the frontal eye field area. And this frontal eye field area, please note, it is for the scanning ocular movement, and it is independent of the visual stimulus. It is for the scanning movement of the eyeball, but independent of visual stimulus. Remember that. So the function of this area is for the scanning ocular movement, and it is independent of visual stimulus. There is no visual stimulus required for this frontal eye field area. That is independent of visual stimulus. This frontal eye field area, guys, if there is injury to this frontal eye field area, what will happen? There will be contralateral voluntary conjugate movement of the eye will be lost. So the conjugate movement of the eye will be lost in case of this frontal eye field area. Conjugate eye movement lost. Conjugate eye movement is lost. So and the eye will be deviated toward the side of the lesion. Remember that also. If let's say the right side frontal eye field area is affected, so there will be deviation of the eye toward the side of the lesion. Although the pursuit movement will be normal. So if you're doing this pursuit movement, you will find that is normal. But apart from, because that is controlled by the occipital lobe, right? But the scanning ocular movement, this voluntary scanning ocular movement will not be there, and you will see the deviation of the eye toward the side of the lesion only. That is the frontal eye field area. Now comes the most substantial and the most important, I would say, that is area number 44 and 45. And you can, the chances of asking the questions in your PGM exam are most on this 44, 45. Situation of 44, 45, it is in the inferior frontal gyrus. It is in the inferior frontal gyrus, and I hope you remember, in the inferior frontal gyrus also, guys, where is 44? 44 is present in the pars opercularis. It is present in the pars opercularis, that was behind the ascending limb, that is pars opercularis. And 45, which is in front, it is present in pars triangularis. It is present in pars triangularis. Remember, pars triangularis between the ascending limb and the anterior limb, that is pars triangularis. 44 or 45, this area is important because this is the motor speech area or Broca's area. This is the motor speech area or the Broca's area. Have you noticed one thing? I mean, if you look at all these areas with a small number like area number 3, 1, 2, 5, 7, area number 4, 6. Now all these basic areas are like for the primary type of sensation or primary type of motor activity. These areas were discovered earlier, so they were named earlier. So they have a like smaller number, 1, 2, 3, 4, 5 like that. And look at all these complicated or more advanced areas like Wernicke's and Broca's area and auditory association. You find their numbers quite high, gustatory area. No? So they have areas like beyond 25 and to 28. There are certain areas, 41, 42, like 44, 45. So higher numbers are usually given to the areas which were discovered later. And that's how this nomenclature went. The Brodmann's classification. So this motor speech area or Broca's area, guys, as we know, any injury to the motor speech area will lead to the motor aphasia. The Broca's aphasia or the motor aphasia. Another important area that we marked in the diagram is 41 and 42. Where is 41 and 42? 41 and 42 is present in the superior temporal gyrus. It is present in the superior temporal gyrus. 41 and 42 in the superior temporal gyrus. Now why this is so important? Because this here is the primary auditory cortex. This is the primary auditory area or primary auditory cortex. We talk about in the auditory pathway also. Primary auditory cortex, also called as Hessel's cortex. This is also called as the Hessel's cortex. Primary auditory cortex or Hessel's cortex. This area number 41 and 42 is surrounded by the area number 22, which is also in the superior temporal gyrus. There only. Superior temporal gyrus. And area number 22, please note, it is the sensory, or I should say it is the auditory association area. This here is the auditory association area. Main auditory area is 41, 42, and it is encircled by this area number 22, that is auditory association area. And lastly, on the superior lateral surface, we got 39 and 40. Now, where is 39 and 40? 39 and 40 is present in, they are present in angular and supramarginal gyrus respectively. Angular and supramarginal gyrus respectively. 39 is an angular and 40 was an supramarginal gyrus. And please note, both these areas are the component of sensory speech area. Motor speech area was 44-45. This 39-40 is a sensory speech area, or you can say it is also the component of the Wernicke's area. It's the component of Wernicke's area. Now I know what few of you might be thinking, that when you say Wernicke's area, especially in physiology, they say Wernicke's area is area number 22. Correct. Area number 22, which is there, which is auditory association area, is corrected by the arcuate fasciculus with 39-40. So please remember, all three are the part of Wernicke's area. So it's not only 22. When you say Wernicke's area, you are actually considering 22, 39 as well as 40. 22, 39 as well as 40, and any injury to this 22, 39, 40, that is the Wernicke's area, will lead to the sensory aphasia. That can lead to the sensory aphasia. Now we just talked about the motor aphasia, and this is sensory aphasia. Motor aphasia plus sensory aphasia. As you know, when both these aphasia are seen together, motor aphasia and sensory aphasia together are global aphasia. That is the global aphasia. We have both the kind of aphasia simultaneously. That is global aphasia, and usually this global aphasia is because of the stroke of middle cerebral artery. It's the MCA stroke which leads to global aphasia. And see, it makes perfect sense. If you look at this superior lateral surface, you don't have to draw it, just understand this. And this here is the Sylvian system, right? That was the Sylvian system. What we have in Sylvian system, I hope you remember, that is the middle cerebral artery. Middle cerebral artery. So I'm saying that middle cerebral artery stroke will lead to the global aphasia. That makes sense. Why? Because it's the middle cerebral artery branches which is supplying the Broca's area, which is here, which is supplying auditory association area, which is here, and it is also supplying this 39 and 40, that is sensory speech area, which is here. So all these areas are supplied by the middle cerebral artery only. So the stroke or the involvement of the middle cerebral artery can lead to the global aphasia. It is the dominant artery supplying the superior lateral surface of the brain. So involvement of the MCA will can lead to global aphasia. So that is about the superior lateral surface of the brain. So guys, now let's look at the medial surface of the cerebral hemisphere and identify the important areas on the medial surface. So for the medial surface, we'll take a sagittal section. Let us say this here is the sagittal section. So this time we are looking at the medial surface of the cerebrum. So this, let's say, is the corpus callosum. Obviously, when you take the sagittal section, you have to take it along the corpus callosum. And this here is the medial surface of the cerebral hemisphere. Take your time, just draw it with me. So this is the corpus callosum here, and that's the medial surface of the cerebral hemisphere. Now what you'll see a sulcus which is running parallel and above the corpus callosum, and you will see that sulcus turning upward like this. This important sulcus is called as cingulate sulcus. This is the cingulate sulcus. And between these two limbs here of the cingulate sulcus, you will see a slight projection of central sulcus. Central sulcus is present on the superior lateral surface of the brain, but you will see a small projection of that central sulcus on the medial surface. And why this projection is important? Because around this central sulcus, but within the limbs of cingulate sulcus, look at this area which I'm highlighting here. This one very, very important area. This area which is actually present around the central sulcus, so we call it paracentral lobule. This is the paracentral lobule. The name goes like paracentral lobule. And why this paracentral lobule is so important? Because the paracentral lobule is the highest center for micturition and defecation. It is the highest center for micturition and defecation. Please note that. It is the highest center for micturition and defecation, the paracentral lobule. So the gyrus that you see, which is present below the cingulate sulcus, that is called a cingulate gyrus only. This is the cingulate gyrus. That is cingulate gyrus. Now let us say this here is the calcarine sulcus. You saw the calcarine sulcus on the superior lateral surface. You can better see it from the medial surface. That is the calcarine sulcus. Now what you see this, if you look at the continuation of the cingulate sulcus posteriorly via this connection that is called as isthmus, I'm just writing I for the isthmus. Via this isthmus, you will see it is connected to this parahippocampal gyrus here. This is the parahippocampal gyrus. This is parahippocampal gyrus that you see present in this part, and this anterior upturned part of the parahippocampal gyrus is nothing but the uncus. I hope you remember the uncus from the lateral relation of cavernous sinus. Remember we said the lateral relation of cavernous sinus apart from the cranial nerves, it was uncus which was outside the cavernous sinus. We also have this para-olfactory in the anterior part. You can see that is para-olfactory gyrus, and the one which is more inside, that is para-terminal gyrus. It is in relation to the lamina terminalis, so we call it para-terminal gyrus. Now my point here is, if you look at all these areas which are kind of encircling the corpus callosum, look at this areas I'm highlighting, guys. This is para-terminal and para-olfactory gyrus. This is what? That is the cingulate gyrus here, right? That is cingulate gyrus. If you see posteriorly, that is isthmus, and then below here we have what? Parahippocampal gyrus, which is anteriorly going and forming the uncus. Whatever I've highlighted here, all these areas which are in the core of the cerebrum, that is the oldest part obviously of the cerebrum, that's why it is in the core, and they are all components of limbic system. Please note that they are all components of limbic system. We've already highlighted the cingulate gyrus and isthmus. So this parahippocampal gyrus, uncus, para-terminal gyrus, para-olfactory gyrus, they are all components of limbic system which you see them in close vicinity along with the corpus callosum. Components of limbic system. Please also note that uncus uncus is area number 28. Now this can be a separate question, that uncus is area number 28, and this is important because it is primary olfactory area. This is primary olfactory area, the area number 28, that is uncus is the primary olfactory area. Around the calcarine sulcus, what you will see, I hope you also remember that posterior part of calcarine sulcus was the example of axial sulcus. So that's why you will see all these important areas which are encircling it, that is a visual cortex can be seen around it. So visual cortex is arranged something like this. You will see area number 17 in the core, then you see area number 18 which is present outside it, that is area number 18. I'm sorry, that is area number 18 here, and then even outside that is area number 19. This is area number 17, that we have is 18, and the one here is 19. Area number 17, as we all know, it is primary visual area. This is primary visual area. And 18 and 19, which is encircling 17, that is visual association area. That is visual association area, that is area number 18 and 19. So these are some important areas, these are some important must-know areas on the medial surface of the cerebral hemisphere. So we saw some important areas on the superior lateral, and these are the areas on the medial surface of the cerebral hemisphere. So having talked about all these important areas on the medial and the superior lateral surface, now let us also talk about the sensory and the motor homunculus. Sensory and motor homunculus will give you an idea about that what part is represented in which area of the cerebral hemisphere. Now guys, unlike, or it is not dependent on the size of the muscle that how much area will it cover, but actually depends upon that what kind of movement is possible at that particular joint or by that particular muscle. Like first of all, please remember that in the cerebral cortex, muscles are not represented. The gross movement is represented. My cerebral cortex is not giving off the order for the bicep muscle to contract. It is giving the order for the flexion of the elbow joint. And then the muscles which are involved in that, the synergist and the antagonist muscle, will accordingly be stimulated. So it's important to understand that cerebral cortex is not having a representation for the particular muscle, but for the particular movement. And the same goes for the sensation also. Whenever we have more sensory input, like if you look at the hand and finger, we have more number of sensory fibers over there. The touch receptors are obviously more in the finger, the tip of the finger, on the face, on the lips. That is why the representation of all these areas is way bigger on the cerebral hemisphere. Similarly, if I talk about the motor area, now let me compare one randomly. If I compare the gluteus maximus muscle with the levator palpebrae superioris, now imagine there is no comparison. Gluteus maximus is a huge muscle, and levator palpebrae superioris is a very, very small muscle. But when it comes to the number of motor unit, the number of motor unit are more in the levator palpebrae superioris, because LPS muscle has to do a fine movement of the blinking of the eye, whereas the gluteus maximus muscle is doing, it's a gross movement, it is for the extension, right? So the more the fine movement is, like the fine movement in the finger done by the intrinsic muscle, intrinsic muscles of the hand obviously will have more representation in the motor cortex, or I should not say muscle, I mean the movement will have more representation in the cortex rather than compared to elbow flexion or the shoulder flexion. So finer the movement, larger this representation in the brain. The more precise the sensation, then we have again the larger representation in the cerebrum. And based on that, there is a schematic picture which is called as a homunculus. Well, homunculus means ghost only, so it looks like a ghost. You'll see a body's inverted lying on the cerebral hemisphere, but that is a very good picture to give you an idea about that what part of the body is represented in which area of the cerebral hemisphere. We said area number 4 is motor cortex, fine. Area number 4 is the precentral gyrus, but in that precentral gyrus, where is upper limb, where is lower limb, where the fibers are trunk coming from, where is the head and neck fibers are coming from. So for that, we need to know about this sensory and motor homunculus. So let's talk about that part in this section. Next topic that we're going to discuss is without a doubt neuroanatomy का एक सबसे important topic है और सबसे ज़्यादा questions जो न्यूरो के अंदर वो इस पोर्शन में से आने के chances रहते हैं, and that is the white matter of the cerebrum. Now we already discussed about the grey matter, हमने different areas देख लिए, हमने different we saw the homunculus देख लिया. अब हम white matter की बात करते हैं. White matter में जो major white matter like internal capsule है, fornix है, corpus callosum है, वो सब cover होना ही है. But before that we also should know कि हम white matter of cerebrum को divide कैसे करते हैं. अब कितने अलग-अलग type का white matter present होता है cerebrum के अंदर. So keeping that in mind, let us start with the white matter of the cerebrum.